The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The broadcast is now starting. All attendees are in listen-only mode.
Good morning, everyone. I'd like to welcome you all to this November 2020 meeting of the Proposition 65 Carcinogen Identification Committee. I'm Lauren Zeiss, Director of the Office of Environmental Health Hazard Assessment, also called OEHHA, within the California Environmental Protection Agency. We really appreciate the committee taking their valuable time to provide us advice and consultation today. We have one main item on the agenda, and that's prioritizing 7 chemicals for possible consideration by the committee at a later meeting. So listing won't be done today, but we will, the main item is prioritization. So I also want to welcome the audience, appreciate your participation in this Proposition 65 meeting. We're really glad we're able to hold this meeting during the COVID state of emergency. We've engaged a go-to webinar specialist, Claire Robinson of LogMeIn Inc., to assist us in this meeting. And she's now going to give the audience some instruction on how to participate in this virtual meeting. And also this meeting does have closed captioning. And so Claire will also point out how to access the closed captioning as well. So Claire?
Great, thank you so much, Director Zeiss. So I'm going to go ahead and go over a few items so you know how to participate in today's meeting. For participants viewing the meeting through the webcast at http://video.calepa.ca.gov. If you would like to provide public comment, you will need to join the webinar at https://bit.ly/MEETCIC. And I can post that into the chat link in a few minutes. Participants joining the webinar will have the opportunity to provide public comment during today's meeting by clicking on the hand raise icon on the left tab of your GoToWebinar control panel. When the meeting chair indicates that he is ready for public comment on that item. Each commenter will be limited to 5 minutes. A voluntary online speaker card can be found at https://bit.ly/OEHHACIC. And again, I will post that shortly into the chat functionality for you. So we invite you to click on that link if you plan to make a public comment. This will help us to ensure that we have heard from everyone who intends to comment. If you would like to present slides and have not previously sent them to OEHHA, please email them to p65public.comments@oehha.ca.gov now. We will show your slides when it is your turn to speak. Just tell us next slide to advance to the next slide. If you have a question regarding logistics, for example, about getting a speaker card or presenting your slides, you may type your question into the questions pane of the control panel at any time during the meeting. Please be advised that this is to assist us with issues that may arise in the virtual meeting process, but is not a mechanism for providing public comment. Closed captioning for this meeting can be accessed at https://bit.ly/CIC/CCAPTIONS. And again, I will post that into the chat functionality very shortly. And now I'll turn the meeting back over to Director Zeiss.
Okay, thank you, Clara. And again, the meeting's being recorded and transcribed, and the transcript will be posted on OEH's website. So before getting into the substance of the meeting, I'd like to introduce the committee. And if you could just wave as I walk through different members. So first, Dr. Jason Bush, Professor of Cancer Biology and Chair of the Department of Biology, California State University, Fresno. And then Dr. Catherine Crespi, Professor in Residence of Biostatistics at the University of California, Los Angeles, Fielding School of Public Health. Welcome to the committee, Dr. Crespi. This is Dr. Crespi's first meeting, so welcome. Then there's Dr. David Eastman, Emeritus Professor of Cell Biology in the University of California, Riverside Department of Molecular, Cell, and Systems Biology. Then Dr. Michelle Lamero, Associate Professor in the University of California, Davis Department of Environmental Toxicology. Dr. Joseph Landau, Associate Professor of Molecular Microbiology and Immunology at the University of Southern California Keck School of Medicine. Dr. Dana Loomis, Professor of Environmental Health at the University of Nevada, Reno School of Community Health Sciences. Welcome to the committee. Dr. Loomis, this is also his first meeting. And Dr. Thomas Mack, Professor of Preventive Medicine at the University of Southern California Keck School of Medicine. Dr. Tom McDonald, Research Fellow, Global Stewardship at the Clorox Corporation. Dr. Peggy Reynolds, Adjunct Professor at the University of California, San Francisco, Helen Diller Comprehensive Cancer Center in the Department of Epidemiology and Biostatistics. And Dr. Mariana Stern, who's Professor of Clinical Preventative Medicine and Urology and the Ira Goldman Chair in Cancer Research at the University of Southern California Keck School of Medicine. Dr. Luping Zhang, Adjunct Professor of Toxicology at the University of California, Berkeley School of Public Health. So welcome, committee, and again, we really appreciate you taking the time to provide your advice at this meeting. And we'll note that Dr. Loomis will be chairing the meeting today on behalf of Dr. Mack. Now, introduce OEHHA staff, and OEHHA staff, if you could just turn on and off your cameras as you're being introduced. So Alan Hirsch, Chief Deputy Director. Carol Moynihan Cummings, our Chief Counsel. Sam Delson, Deputy Director for External and Legislative Affairs. Dr. Vince Cogliano, Deputy Director for Scientific Programs. This is also, I think maybe for some of you, Dr. Cogliano, this is Dr. Cogliano's first meeting, and he comes to OEHHA with a wealth of experience from US EPA and the International Agency for Research on Cancer, and he is our Deputy Director for Scientific Programs. So welcome, Vince. And then from the Reproductive and Cancer Hazard Assessment Branch, Dr. Martha Sandy, the branch chief. Dr. Meng Sum, she's our new section chief of the Cancer Toxicology and Epidemiology section. And from the Proposition 65 Implementation Program, Julian Lichty, Special Assistant for Programs and Legislation. Now I'll ask Carol Moynihan, our Chief Counsel, for some introductory remarks for this meeting. Carol?
Okay, good morning. It's a little strange having you all look like Hollywood squares up here, but we'll do our best to make this work. The staff is only going to be showing cameras when they're speaking. So if you need to speak to one of us, then just say that and we'll go ahead and get on camera and unmute. As you know, today's meeting concerns the prioritization of chemicals for future potential listing discussions. No chemical listings will be considered at the meeting today. Your discussion and recommendations concerning priority will inform OEHHA's decisions concerning potentially bringing a given chemical to this committee for consideration at a future meeting. Your advice is not binding on OEHHA, but is very helpful to us in planning for future meetings. Our scientific staff will explain the prioritization process in more detail shortly. OEHHA takes no position regarding whether a chemical should be prioritized or what priority that may be, though our staff are available to answer questions or locate information if you need it. The governor appointed you because of your scientific expertise to be the state's qualified experts on the carcinogenicity of chemicals, and there's no need for you to feel compelled to go outside that charge. This committee can consider human, animal, mechanistic, or other data when making a recommendation to OEHHA on priority. You can also consider exposure potential for a chemical, but you don't need to consider whether or not the current levels of exposure are sufficient to cause any harm. So what you're looking at is whether or not there's potential for exposure in California or the US. Feel free to ask clarifying questions of me or any of the other staff during the meeting. If we don't know the answer to your question, we'll do our best to find and report it back to you. Please also remember that all discussions and deliberations need to be during the meeting, not during breaks, lunch, or with individual members on or offline. I also wanted to let you know that Mario Fernandez on my staff, he's a senior staff counsel, may need to cover for me at some point during the meeting. He's very qualified and can answer your questions, and he can also reach me if necessary. I just want to remind you that you do need to mute when you're not talking. This is a public meeting and everyone can hear what you're saying. So any questions? No. Okay, thank you.
Okay, thank you, Carol. And now I'll turn the meeting over to Dr. Dana Loomis, today's meeting chair.
Thank you, Lauren. Good morning, everyone, and thank you for joining us under these rather strange circumstances. I'm very happy that we can still meet virtually in spite of the current pandemic. As you heard earlier, this is my first meeting, and so not only have I not been to one of these meetings before, I haven't chaired one. So if I get things wrong, we'll ask fellow members of the committee or the staff to help me out. I'll also point out that we do have a scheduled lunch break around noon. When the time comes, I'll announce that in between discussion of some of the items on the agenda. And we'll also try to take a short break about every hour for 5 or 10 minutes. So again, thanks everyone for joining us. As you've heard before, we have one principal agenda item, and that is the prioritization process where we, the committee, are asked to advise OEHHA on the priority of 7 chemicals for future consideration for listing. And so we'll turn to that agenda item in just a moment. But before we do that, I'll ask Dr. Martha Sandy to open the presentation of the process by the staff.
Thank you, Dr. Loomis, and welcome CIC members. Usually for prioritization, I'm the one that gives a background presentation on the prioritization process, but I'm pleased to tell you that today I'm going to ask Dr. Meng Sun, who is the new section chief of the Cancer Toxicology and Epidemiology section, to give that presentation. So I'll turn it over to Dr. Sun.
Thank you, Dr. Sandy. Good morning. Clara, could you show my slides, please? Thank you. So the main item that we're going to discuss today is the prioritization of chemicals for possible future CIC review and listing consideration under Proposition 65. As several of our CIC members have joined the committee after 2016, which was the most recent year we brought chemicals for prioritization ranking, I'm going to give a brief overview of this prioritization process. Next slide, please. The purpose of the prioritization process is to identify chemicals for evaluation of cancer hazard by the CIC. Specifically, we track chemicals that we think have some evidence of carcinogenicity, and we then prioritize among this large group of chemicals. The goal is to identify chemicals that the CIC should evaluate. We want to focus your attention on chemicals that are relevant for Californians. So we look at chemicals that we think have apparent exposure in California. And then we look at chemicals with the most information that suggests that they might be carcinogenic. I want to emphasize that prioritization is a preliminary appraisal of the evidence of hazard. It is not a thorough, comprehensive review like we do when we write a hazard identification document. The prioritization process is meant to be a quick screen of readily available data relevant to carcinogenicity for a large number, hundreds of chemicals. Next slide, please. Here is a schematic of the prioritization process we follow based on the top portion of Figure 1 in OEHHA's 2004 prioritization process document, which has been provided to you as part of this meeting's materials. Let me walk you through this slide. We maintain a chemical tracking database shown at the top of the slide, and among the chemicals that are tracked, we identify those that have apparent exposure in California and some evidence suggestive of carcinogenicity. This subset of tracked chemicals are called candidate chemicals. We apply focused data screen to those candidate chemicals. By that, I mean that we conduct focused literature reviews to identify chemicals that report positive findings in cancer epidemiological studies in humans, and thus pass our human data screen, and to identify chemicals that have certain types of positive tumor findings in studies in animals, and thus pass our animal data screen. Chemicals that pass either one or both of these data screens continue further in the prioritization process. They are subjected to a preliminary toxicological evaluation of the overall evidence of carcinogenicity, taking into account additional information such as studies on key characteristics of carcinogens, metabolism, and pharmacokinetics. Chemicals for which this preliminary evaluation indicates carcinogenicity may be a concern are proposed to you for consideration, and we consult with you in a meeting like we're doing today. After the meeting, we will consider your advice, and OEHHA will select chemicals for preparation of hazard identification documents. Next slide, please. Here is a recap of our past and present prioritization efforts. Between 2009 and 2011, we applied the human and animal data screens to more than 380 chemicals. For chemicals that passed either one of those data screens, we looked at the overall evidence by conducting a preliminary toxicological evaluation and identified those with the most compelling evidence to bring to the CIC for consultation. Over the course of those 3 years, we brought 104 chemicals to this committee, asking the committee to rank each chemical in terms of priority as either high, medium, low, or no priority. On an ongoing basis, we continue to look for new information on tracked chemicals and on those identified as candidate chemicals by conducting updated literature searches. And as new chemicals are added to our tracking database, we screen them for exposure in California and evidence suggestive of carcinogenicity. For all chemicals newly identified as candidate chemicals, we apply the human and animal data screens. Also on an ongoing basis, as we identify chemicals that pass the human and/or animal data screens, we conduct a preliminary evaluation of the overall evidence and identify those with the most compelling evidence as chemicals to bring to you for consultation. In 2016, we brought 5 chemicals to your committee for consultation and prioritization ranking. And now in 2020, we're bringing 7 chemicals to you. Next slide, please. Now I would like to focus specifically on the part of the prioritization process shown here on the slide, where candidate chemicals are screened, first by applying a human data screen to the results of a focused literature review, and then by applying an animal data screen to an appropriately focused literature review. For chemicals that pass either of these screens, we proceed to step 3, as shown on the slide, in which we conduct a preliminary toxicological evaluation of the chemical. That entails consideration of the overall evidence from readily available information relevant to carcinogenicity, including findings from human and animal studies and mechanistic and other relevant data. Based on these preliminary evaluations, we identify chemicals with the most compelling data as chemicals to bring to you for consideration, consultation, and ranking. Next slide, please. This slide summarizes the human data screen that we apply. It is meant to be a quick tool to identify candidate chemicals with some positive findings of carcinogenicity that have been reported in humans. We look for cancer epidemiological studies that report a positive association between exposure to the chemical of interest and the increased cancer risk. More weight is given to analytical studies and less weight to descriptive studies and case reports. In addition, studies reporting positive associations are reviewed to determine whether the cancer effect might be attributed to the chemical with some confidence. If so, the chemical passes the human data screen. Next slide, please. This slide summarizes the animal data screen that we apply. As with the human data screen, this screen was designed as a quick tool to identify candidate chemicals with a certain minimum amount of positive findings in animal studies in order to distinguish from those that do not have that minimum level of positive findings in animals. And for the newer members of the CIC, I will note that back in 2008, as we developed the animal data screen, we consulted with the committee on the design and content of the screen. As shown here, there are several ways in which a chemical can pass the animal data screen. The first is if a chemical has 2 or more positive animal cancer bioassays. And I should point out that for purposes of this screen, we have defined a positive animal cancer bioassay as one in which an increased incidence of a malignant or combined malignant and benign tumors is observed. Other ways in which a chemical can pass the animal data screen is if there is one positive study in which the tumors occur to an unusual degree with regard to incidence, site, or type of tumor, or age at onset, or if there are findings of tumors at multiple sites in that single positive study, or if in addition to that one single positive study, there's a second animal study reporting an increase in benign tumors known to progress to malignancy. Next slide, please. This slide highlights where we are today in the prioritization process. We are at the stage where we're consulting with the CIC on the 7 chemicals that we have proposed for committee consideration. Next slide, please. Your committee in the past has asked us to put the table together like this, where we have characterized each of the chemicals in terms of exposure, and where we have identified the types of studies available for each chemical. With regard to exposure characteristics, chemicals may be identified as being widespread or high in frequent consumers, or as having limited exposure, perhaps only in occupational settings, or as being high in infrequent consumers. In terms of the types of studies that are available for each chemical, for the different types of data, human, animal, and other relevant data, we are indicating with a check mark the types of studies that are available. For example, a check mark in the analytical human data column indicates that there is at least one analytical human study on the chemical. Such a checkmark does not indicate whether there are any analytical epidemiological studies with positive findings, however. It merely indicates that there is an analytical epidemiological study on that chemical. Among the 7 chemicals included here in this table, Deca-BDE and PFOS were brought to the CIC in 2010, and they were ranked at that time as medium priority. Bisphenol A and trifluorelin were brought to the CIC in 2011, and they were also ranked at that time as medium priority. Since that time, significant new data have been identified for all 4 of these chemicals, so we're bringing them to you again today. This is the first time that chlorpyrifos, coal dust, and methyl bromide have been brought to the CIC for consultation. I'd like to explain that under the structural similarity with Proposition 65 carcinogens column, we have check marks for 5 chemicals. In our prioritization document, we inadvertently missed specifying the names of these carcinogens for 2 chemicals. For bisphenol A, it is similar to the carcinogen tetrabromobisphenol A. And for PFOS, we apply the structural activity relationship broadly to fluorinated chemicals such as tetrafluoroethylene. I also wanted to point out that PFOS is structurally similar to PFOA, or perfluorooctanoic acid. PFOA is currently ranked as a high priority chemical. Next slide, please. Today, we're asking you to recommend rankings for these 7 chemicals in terms of priority for preparation of hazard identification materials for possible future CIC review and possible listing under Proposition 65. You will notice that we are asking you to rank these chemicals as either high, medium, or no priority. And now I will turn this over to OEHHA's Deputy Director, Dr. Vince Colliano, to say a bit more about these 3 priority categories.
Thank you very much, Mung, and good morning, everybody. So those of you who've been to more prioritization meetings than I've been will remember that in the past you've been asked to rank chemicals as high, medium, or low, or no priority. And in going over the materials, we realized that saying that we should consider a chemical with low priority is a bit of a mixed message. That it's really saying it's not much of a priority at all. So to be totally transparent and clear, we decided to not use that category going forward, and to just ask you to make your recommendations be high priority, medium priority, or not a priority. So that's the change we're making for this meeting compared to meetings in past years. And so with that, that's all I have to say at this time. Thank you.
Thank you, Dr. Colliano. That concludes our presentation today, and I will now turn it over to Dr. Loomis.
Very good. Thank you, Mung and Vince. So we're in just a moment, we'll begin the committee discussion phase of this meeting. I'll take a minute to explain how this will work. We have 7 chemicals on the agenda today. For each one, 2 or 3 members of the committee have been designated as lead discussants. So I'll call on each of the lead discussants by name and ask them to give their views of the chemical and a preliminary suggestion about whether it warrants priority for further consideration. We'll then call on other members of the committee if they would like to make any remarks. And then having done that, we'll have time for public discussion. Public discussion will be limited to 5 minutes per speaker. And at this point, I'll ask our facilitator, Claire Robinson, to explain the mechanics of that process.
Okay, thank you. So I'm just moving to the next slide here. So for the public comments, if you wish to provide a public comment, please use the hand raise feature that is located on the left tab of your GoToWebinar control panel. We will see your hand raised and we'll ask you, and we will unmute you so that you can ask your question. Again, if we do request that you fill out a speaker card, and I put the link into the questions pane earlier where you can fill that out. And again, if you would like to present slides and you have not already sent them to OEHHA, please send them to the email that is located on the slide that you are viewing right now. And if you need any assistance during the virtual meeting, you can submit questions to the questions pane in the control panel. Before we get started with that, Dr. Loomis, I just wanted to see if we wanted to take a quick break just to verify the recording situation.
Sure. If we need to do that, let's take 5 minutes. Is that enough?
Hopefully, yes.
Okay, I have one more point to make about the discussion process, and then I'll call for a break if that works for you.
Sure.
Okay, so we've heard about the public comment process. Then, having heard from all those members of the public who wish to speak, I'll come back to the committee and ask for further discussion and a vote on priority, calling on each member of the committee to give their opinion. So if there's nothing further we need to discuss about the process at this point, let's take 5 minutes for a technical break.
Okay, I think we can get started, Dana. I think we can start back up.
Okay, very good. So if everyone is here, I think I see all the committee members. Then let's get started with the scientific portion of the meeting. That means we begin with the first chemical, bisphenol A. So for this substance, Joe Landolf, Michelle Lamerrill, and Peggy Reynolds are the designated lead discussants. So Dr. Reynolds, let's begin with you.
Okay, as has been nicely outlined by the OEHHA staff and as well as from public comments from the American Chemistry Council, BPA is something that's been used since the 1950s to make highly durable plastics and has been commonly used in food packaging. Exposure in humans is ubiquitous, but BPA has been subject to extensive negative press and recently been discontinued from use in many of food and beverage packaging products, as has been illustrated on the BPA-free notation seen on many products. So while I defer to my colleagues on the toxicology and mechanisms of BPA, there does appear to be good evidence for xenoestrogenic properties that raise concerns about carcinogenic potential, particularly for hormonally mediated tumors. An NIH EPA expert panel review in 2007 documented that endocrine disrupting properties had been demonstrated in several in vivo studies, and that BPA should be considered to be a xenoestrogen. A 2016 update further reinforced that conclusion, and panel members concluded that BPA may be reasonably considered to be a human carcinogen for breast cancer. There's also some epi-evidence that BPA may be associated with greater mammographic density, which is well known as a risk factor for breast cancer. But in fact, the epidemiologic evidence was then and still is pretty sparse. So one of the biggest challenges for human health studies of this nature is exposure assessment. The most common method for assessing exposure in humans is from measuring metabolites in urine. Assessing BPA in blood is less desirable as detection levels tend to be low and less informative, and roughly half of the few epi studies to date have relied on urine samples. There's only a small smattering of studies. There were 13 studies presented to us for this initial review. Most of them were breast cancer, 7 of the 13 studies, and of those 4 had exposures from urine samples. Generally, the breast cancer literature has been quite null, as has been the one study on endometrial cancer, which was a study based on blood samples. It's not surprising that so many of these studies were breast cancer because of the endocrine disrupting and estrogenic activity of BPA. But despite various approaches to exposure measurement, they, along with that one endometrial cancer study, haven't really observed elevated risks, while there appear to be positive results for a few other miscellaneous cancers. This could be in part because the animal evidence for in utero BPA-related epigenetic reprogramming suggests that the design of most current epi studies may have been looking at the wrong window of exposure. This is a general problem for studies of breast cancer. So, although there are relatively few epidemiologic studies of BPA and cancer risk, and only a few of those are positive, the laboratory evidence, in my mind, continues to suggest potential risk relationships for humans, particularly for those endocrine-related cancers. So because of the extensiveness of BPA exposure in the population and high public interest in human health risks, I would classify this as a high priority for CIC review.
Good, thanks, Dr.
And
Reynolds.
I'll pass it on.
Okay, let's go on to Dr. Landolf then.
I'm sorry, Dr. Landolf, if I could just interrupt quickly. I'm not seeing everybody's cameras on for the committee. Could you check and make sure, all of you, that you have your cameras on? In particular, Dr. Reynolds? Okay, yeah, we just need Dr. Reynolds, I think. There you are. Okay, thank you.
Okay. Yeah, I agree with Peggy. It certainly is a high exposure chemical to humans. And to make a long story short, the last time we looked at it, I voted medium on it, but there's been a lot of data that's come in on it since. So I'm going to shift my vote to high. I'm looking at the two hydroxyl groups on there, and it looks like potential for the possibility of oxidation to quinones, and that you could generate oxygen radicals off this. So I want to turn to the animal studies I'm more conversant with. And let's see here. Table 3 is male Fisher rats, 344 rats exposed to bisphenol in feed for 103 weeks. And the hematopoietic system, looking at leukemias, they got 13, 12, and 23 at the 0, 1,000, and 2,000 parts per million doses. The trend test was P equals 0.021, so that's good. The mammary gland, they looked at fibroadenoma 0, 0, and 4, and the trend test was P equals 0.0114. And the testes, they looked at interstitial tumors, and they got 35, 48, and 46, roughly out of 50. And the trend test there was good at P is less than 0.001. So that was a hematopoietic system mammary testes. In table 4, the results were not quite as striking. The hematopoietic system was 2 out of 50. At 0 at the medium dose, it was 8 out of 50, and at the high dose of 10,000, it was 3 out of 50. So it was a rise, but it was not significant. For the chromophobe carcinoma in the pituitary gland, it went 0 tumors at 0 dose, 0 tumors at 5,000, then it jumped to 3. So the P equals less than 0.05. So that's positive. There was a positive test for tumor incidence in female F1 Sprague-Dawley rats exposed during gestation, and the numbers were low, but there was a P test of P equals less than 0.05. So that's positive as well. And there was a whole set of lymphomas arising in different organs: liver, prostate, bone marrow, spleen, kidney, and systemic in male F1 Sprague-Dawley rats exposed to bisphenol A during gestation. And the trend test was pretty good for all of them. It was less than 0.01, except for one, which is was less, as P equals 0.002. So I'm going to skip over a lot of this and say I see a lot of positivity in the animal studies. So basically, I'm going to stick with high, and I want to turn just real briefly to the in vivo studies, and you get DNA adducts in CD1 male rat liver is positive, and in vitro you get formation of DNA adducts to the N7 of guanine. So that's positive, and DNA adducts in cultured serum hamster embryo cells, positive. So that indicates that you're getting DNA adducts from metabolism of this compound. Then in genotoxicity, you get DNA double-strand breaks, meiotic aneuploidy in females. In vitro, you get KRAS mutations, HGPRT mutations in B79 cells was negative, however. You get micronucleus formation, you get aneuploidy, you get chromosomal abnormalities, and DNA double-strand breaks in a number of different systems. So I would say, since we last met, this compound is much more positive. It induces chronic inflammation, and it does cell transformation in serum hamster embryo cells. So I'm going to go along with Dr. Reynolds and say that my recommendation is we move this one up to high, both because of the widespread exposure and the large number of positivities in the animal studies.
Okay, thanks, Dr. Landolf. Let's go on to Dr. Lamerrill.
Good morning. I'll give you my overall impression and then dive a little into it further. I've noticed in humans and rodents, there are reports of mammary cancers and prostate cancer or neoplasia that are consistent with interactions with multiple nuclear receptors, primarily those of estrogen, and further evidence that those estrogen receptor interactions have pretty nicely elucidated epigenetic gene regulatory mechanisms associated with them. And there's evidence that there's estrogen receptor dependent proliferation, and these combined with reduced apoptosis and elevated genotoxicities make me think that this should be a high priority. When I looked at the human data, I only looked at the case controls. I noted there were no cohort studies. We heard from Dr. Reynolds how the exposure assessment is problematic, both in terms of this being a short-lived in terms of half-life, but also windows of susceptibility issues. Despite those practical difficulties in conducting this research among case control studies, 2 out of 4 had elevated odds of breast cancer, and 2 out of 4 were null. For other sites, there was only 1 representative case control study that I observed, and they had elevated odds for lung cancer, prostate cancer, meningioma, brain cancer, in addition to osteosarcoma and a gene interaction with lysyl oxidase, LOX genotype. In the animal studies, as you heard from Dr. Landolf, there are extensive sites that were targeted, mostly of hematopoietic and endocrine reproductive axis, and both male and female rodents, and this was across government and academic labs at least, and this included both rats and mice, involving primary exposures, co-exposures, and xenographic approaches, and these sites and lesions included pituitary carcinomas, mammary carcinoma, hepatic adenoma, and carcinoma combined, lymphomas in multiple sites, prostate neoplasias, or often known as PINs, and adenocarcinomas. So there were numerous demonstrations of dose response trends, but also sometimes those only were pairwise. And you heard a lot about the genotoxicity from Dr. Landolf. I mentioned there's quite a bit known on epigenetic effects of BPA that are primarily associated with histone modifications and the estrogen receptor. There is a study of chronic inflammation in rabbits. The estrogen receptor that is targeted is not just nuclear alpha and beta, but also the membrane G protein coupled estrogen receptor. And this has been demonstrated in a number of different species and with selective antagonists to have dependence for downstream effects, including neoplastic transformation of human breast epithelial cells. There is some evidence of immortalization by transformation of hamster embryo cells as well. And with that, I think I'll stop and just reiterate that I would recommend this as high priority based on that weight of evidence.
Okay, great. Thanks to all the discussants. And now let's see whether other members of the committee have anything that they'd like to add to what we've already heard. The process for this, as I understand it, is going to be, since I can see all of you, you physically raise your hand and I'll call on you. So Dr. Eastman, you have your hand up. Go ahead, please.
Thank you. I have a kind of a different take, certainly on the animal studies. I didn't review this chemical in great detail, but I did notice that the NCI-NTP chronic bioassay results, although they noticed these various trends, they recognized most of these were associated with old age. And so they concluded there was no clear evidence. This is from the 1992 one, I believe, or 82, I can't remember. And then the more recent Clarity study, which was done by NCTR, although there's some controversy, overall it's pretty negative in the animal studies, like overwhelmingly negative. Now, positive results were seen in many different endpoints as far as estrogenic activity, et cetera. But as far as cancer itself, I didn't see the evidence for that. I'm not familiar with it. I do recognize it is an estrogenic compound. It's about 1 It's not nearly as potent as estrogen. I think it's 100-fold or 1,000-fold less potent. So at high doses, you will see effects, but when you get to the low dose is where most people are exposed. It's really questionable whether you see those effects or not. Anyway, I do realize this is a high-profile compound. There's a lot of concern about it. There's certainly mechanistic information. So, I would tend to put it more in the medium category, but that's my, and the main thing for me is I don't really mind going through it, but there's a huge amount of work involved with the OEHHA staff. So that's kind of my thinking about this compound.
Okay, thanks, Dr. Mack. I think you had your hand up as well. Looks like you're on mute.
Yes, I have a completely different reason for wanting to put it in a high priority, although I think it should be just on the basis of its universal exposure and the relatively minimal animal data. But there's my attention was caught by the Chinese study of what they initially said was non-small cell lung cancer. This is something that an epidemiologist probably wouldn't do initially, because non-small cell lung cancer puts together two cancers which have completely different etiologies. The standard, formerly most common kind of lung cancer, which is very much tobacco related, and adenocarcinoma of the lung, which is a very different entity. The standard kind of lung cancer is decreasing in frequency because of the decreased number of people that are still smoking. And it is most common in Black men and Black women, and then on whites after that. But adenocarcinoma is very different. It not only is it is most common in Black men, but it's most common in white women, and it's a very striking difference. And it's also not decreasing in frequency as the other lung cancers, which are related to tobacco, are. It's increasing, and it's increasing in both men and women. And because that study in China was, in fact, basically a study of adenocarcinoma, because it's by far the most common non-small cell lung cancer in China. And the numbers were fairly large, and the result was fairly positive. So because of the fact that white women may have a different kind of exposure than Black men, and because this tumor is increasing, I think it warrants a high criteria as well.
Thanks for that interesting observation. That's worth keeping in mind. Let's see. Would any of the other members like to make a comment at this point? Let's see, Dr. Eastman, any other hands? Let's go to Dr. McDonald first, then we'll come back to you, Dr. Eastman, since you've already spoken once. Go ahead, Dr. McDonald.
Yes, thank you, and hello, everybody. Yeah, I also, like Dr. Eastman, I wasn't as compelled with the animal evidence. The 1982 NTP study did have some suggested findings, particularly the rare mammary gland fibroadenoma in the high-dose males. But overall, those early studies showed maybe some suggestions by trend test in the mice, but not by pairwise. And then the later studies by NTP in 2018, generally I view those as negative. There's some suggestions maybe if there's a U-shaped dose response curve or something like that going on, but you just don't see responses in the higher dose groups. Clearly there's lots of mechanistic evidence on this compound. I think the only other thing I'd like to add is on the epi studies, I'm a little worried that in nearly all the studies, exposure assignment is by a single urinary sample, for a chronic endpoint. And so that's one area of concern where I find is a little bit of a weakness in the human data, but I'll let the epi folks speak to that. Thank you.
Okay, Dr. Eastman, did you want to say something else?
Oh, this was just to follow up with Dr. Mack's comment. I thought the shift in tumor types in lung cancer had to do with the reduction in the coal tar, the PAH, and the increase in nitrosamines in the cigarettes. And that's why there was a shift in lung cancer being seen. That's just to follow up to your specific comment.
Okay, Dr. Lamero wants to say something else, so go ahead, please.
Yes, thank you. So to speak to the comments about the NTP studies, I am a little perplexed about the conclusion that there's not really anything going on in the 1982 study. The trends are significant, which means that there is a linear dose response associated with that. I heard also that there was not a pairwise association, but in fact at the higher doses it was observed, and I see that in particular that there was a trend significant for hematopoietic with leukemias, the fibroadenoma of the mammary gland, as well as the interstitial cell testes tumor. And with respect to the point-wise doses, there was significantly elevated leukemias and testes tumors in the 2000 ppm dose group compared to the control, and for the testes in the 1000 group. I also heard mentioned that there was sometimes a non-monotonic. I think it's confusing to me to hear you on one side saying, Dr. McDonald, that we shouldn't be too interested in the trend test, and on the other hand, you're saying that the non-monotonic and not much effect at the higher dose is to be dismissed. I'm not really sure what type of pattern of significance it is that you find remarkable, but I want to point out that regardless of our interpretations of the statistical significance that was actually reported, that across multiple models we have in multiple species, rats and mice, and both males and females, carcinomas in 2, 3, 4, at least 4 different sites. And so based on the criteria that we're supposed to be thinking about elevated concern for animal studies, I think this is kind of more than adequate to consider this worth for a full review, to look more carefully at some of these studies that are being brought up.
Okay, thanks. Dr. Bush.
Thank you. Yeah, just a matter of procedure, and perhaps Dr. Zeiss or Sandy could answer this. Do we know whether DART is evaluating this particular chemical?
Hello, this is Martha Sandy. Yes, I can tell you that actually bisphenol A has been listed by the DART IC committee. They considered it just for one endpoint, the female reproductive endpoint, and it was placed on the list based on that. And you'll be hearing at the end of the meeting about a court case where we had proposed listing BPA based on developmental toxicity and through the authoritative bodies mechanism. And that case is winding its way through the process. So we'll update you on that at that time.
Thank you.
Good. Are there any other preliminary comments from the other members of the committee who haven't spoken yet? I don't see any hands raised, so I'll add mine really briefly. I agree that the epidemiologic evidence of carcinogenicity is inconsistent. We'd call it limited in IARC terminology. But nevertheless, there's a concern about widespread exposure to this chemical and its high public profile. I also noted that there's evidence that it induced oxidative stress and chronic inflammation in 2 studies of exposed humans, which I don't think was mentioned in earlier comments. So for me, it would merit high priority for further consideration. So unless there are any further, last thoughts, there's Dr. Stern. Go ahead, please. You're on mute.
I don't want to take too much time, but I just want to add my thoughts. I agree that the epidemiological evidence is consistent with limited based on lack of findings for some cancer types, primarily for breast cancer, where based on the mechanisms one would expect to see stronger associations. But I want to echo what Dr. Reynolds said, that based on the mechanistic evidence, it suggests that the impact of this compound might be during development. And there are no studies that have looked at cohorts to see whether young women exposed during childhood or development are impacted by these. So, but the mechanistic evidence to me is compelling in that direction. And there are some cancers like lung and prostate and meningiomas and bone cancer for which there are positive associations. So putting all together, I think that it merits further evaluation and it's of high impact based on the concern of potentially the impact it may have on young women during development.
Okay, thanks. Any final comments before we invite the public to speak? Dr. Landolf, one more time.
Yeah, I'm going to agree with Dr. Stern and Dr. Merrill. When I looked at this, there is positivity in the animal database. So I don't think you can just put a 0 coefficient in front of that. I don't agree with that. Secondly, the key characteristics of carcinogens is met in a few areas here. It forms DNA adducts in vivo and in vitro, and it's genotoxic. And it causes aneuploidy in SHE cells. So there's a lot of classical contributions of the principles of carcinogenesis to this compound. I ask myself, could I say that this compound is not carcinogenic? And I would have to reject that hypothesis straight out of hand due to the large amount of evidence that I see presented here. So I disagree with some of the other speakers.
Okay, thank you. Let's go now to public comments. The committee will have a chance for further discussion after that. And I see that Mr. Henkes has his hand up, and so I think we need our facilitator to call on him to speak.
All right, Mr. Henkes, I have unmuted you from our end, but you are currently self-muted. You should see an icon of a microphone on the top left corner of your control panel. Please click on that to unmute yourself from your end. There you go. Hi, Steve. Can you hear us?
Hello, can you hear me now? I should be coming through. Okay.
You are.
Okay, thank you. I sent in written comments before, and probably you have those and have looked at those. So what I intend to do is to provide a hopefully brief synopsis of some of the key points from the written comments, hopefully within a 5-minute timeline. So first, what is BPA? It's an industrial chemical. It's primarily used to make polycarbonate plastic and epoxy resins. About 75% of BPA is used to make polycarbonate, about 20% for epoxy. Small amounts are used to make specialty plastics and resins. Only trace levels of BPA, residual BPA, remain in the finished materials, typically less than 100 ppm. Human exposure has limited potential from the use of polycarbonate and epoxy products. The human exposure in general has been well studied with biomonitoring studies that consistently show exposure is very low, typically less than 100 nanograms per kilogram per day from all sources. It does not distinguish between one source versus another. And those exposures are well under TDIs that have been set worldwide. Those are in the range of 4 to 50 micrograms per kilogram per day. So human exposure is well below the TDI levels. As far as metabolism and pharmacokinetics, BPA has also been well studied. It is efficiently metabolized and rapidly eliminated from the human body in urine. After exposure, metabolism converts BPA to biologically inactive and non-estrogenic conjugates. Mostly that means BPA glucuronide and lower amounts of BPA sulfate. Those are the things that are found in urine in biomonitoring studies. It's reported as BPA, but those are what's actually present. Unconjugated BPA in urine is typically 1% of the administered dose, administered meaning the doses in pharmacokinetic studies. Consistent results from several human pharmacokinetic studies and numerous animal studies have been found. These results indicate that BPA is very unlikely to cause health effects at any foreseeable exposure level. BPA has been comprehensively reviewed by agencies and organizations around the world. Those consistently find that there is little concern for carcinogenicity, and there is no different conclusion from government agencies or Proposition 65 authoritative bodies. Reviews of BPA have been conducted around the world. That in the US principally includes the US Food and Drug Administration, but also Europe, Japan, and some years ago there was a joint expert meeting that was sponsored by FAO and OEHHA. All of these reviews, or most of them, also conclude that BPA is not mutagenic. The mentioned earlier were the NTP studies that were conducted, the bioassays on BPA that were conducted on rats and mice. Those I consider to be the seminal studies. There was no evidence for carcinogenicity in female rats and male or female mice, and equivocal evidence in male rats. More recently, this was also mentioned, FDA was subjected to a 2-year toxicology study by FDA in the so-called Clarity Core study. That study began exposure during gestation, and exposure ranged over a wide range from low to much higher doses of BPA. There was little evidence in that study that BPA could be carcinogenic. BPA also has been subjected to numerous in vitro and in vivo genotoxicity assays. The weight of evidence from those assays indicate that BPA is not genotoxic, especially that would be true in the most relevant in vivo studies. So in conclusion, based on the extensive scientific database available for BPA, we recommended that BPA be designated as low priority, and I realize now that you've actually eliminated that categorization. And so maybe no priority or medium would be the correct recommendation on that. So we recommend basically that it's not the highest priority for your further consideration. So hopefully I finish in 5 minutes. We'll stop there and we can go to the next commenter.
Okay, thank you very much, and thanks for staying within the time limit. I understand that there may be another member of the public who wants to speak, but I don't see another hand raised. So, okay, so Clara is indicating there is no other public comment. So if that is the case, then we go back to the committee for final discussion and vote on priority for this chemical. Any further thoughts about BPA from the committee? Okay, I don't see any other comments, so I'm going to call for a vote on priority for bisphenol A in the order in which I see you on the screen. Dr. Lamerle?
Sorry, I had to navigate to my mute button. I vote for high, please.
Thanks. Dr. Crespi?
Aye.
Dr. Bush?
Aye.
Dr. McDonald?
Medium.
Dr. Stern?
Hi.
I vote aye. Dr. Zhang,
Hi.
Dr. Mack. I see you speaking, but I don't hear you.
Hi.
Heard it that time. Dr. Eastman.
Medium.
Dr. Landolf.
Hi.
Dr. Reynolds.
Hi.
Okay, I don't think I've missed anybody, but if I did, please shout. Sounds like the majority say hi. So let's move on to the next chemical, and that is chlorpyrifos. And we'll do this one in the same way. I'll call on the lead discussants first. Dr. Crespi, first you, and then we'll go to Dr. Lamero.
Sure, thank you. So chlorpyrifos is an organophosphate pesticide. As far as exposure goes, the State Department of Pesticide Regulation is banning all agricultural use in California at the end of this year, based on findings of developmental neurological effects in children at small doses and other health effect issues. So it's expected that exposure to the general public after the end of the year would primarily come from residues on food that are food that's grown out of state. So that would be the primary mechanism, primary route of exposure after the end of this year for folks in California. I was focusing on the epidemiological evidence, which is more in my wheelhouse. Most of the literature, published literature, comes from a particular prospective cohort study, the Agricultural Health Study, which was a study of over 8,000 farmers and pesticide applicators and their spouses in Iowa and North Carolina. And that study enrolled folks starting in 1993 to 97. And it collected exposure data to about 50 pesticides prospectively through self-report, through questionnaires, which is a strength of this study with the prospective exposure data collection. And the incident cancers were identified by linkage to the state cancer registries. So it's a very large prospective cohort study with a number of strengths. So I think relatively low risk of bias for this type of study. And that study's been pretty well mined in terms of looking at multiple different types of cancer and whether risk is associated with the various pesticides and classes of pesticides for which exposure data was collected using various different exposure metrics. There were shorter term studies that were published in the mid-2000s, and then some longer term follow-up published more recently with about 15, 20 years of follow-up. So most of the human analytic data comes from this particular study, and then there are some various case control studies which have looked at this chemical, most of which are relatively small. So I think, as I mentioned, the agricultural health study especially looked at a lot of different cancers. And I think that the most noteworthy positive results found are for breast cancer and kidney cancer. So there was an earlier study with shorter follow-up that found some evidence of elevated risk of breast cancer among, principally among the spouses, although some of the spouses applied the chemicals directly. So there was husband's use and then also direct use. among this, the female part of the cohort. And so this is looking at like 30,000 women and over 1,000 breast cancer cases, and they did find elevated hazard ratios on the order of 1.5, statistically significant. And then there was also another study that looked more closely in terms of tumor type and found a positive association with estrogen receptor negative, PR negative tumors in postmenopausal women with a risk ratio of about 2.3, and that was statistically significant. So those are, I think, some notable positive findings for breast cancer. And I think also supporting a concern for breast cancer would be a case control study that was a population-based case control study that was conducted in the Central Valley of California. It was relatively small with 155 cases and 150 controls. The exposure assessment was done using historical pesticide application data and geolocated location histories for the subjects. And it did find odds ratios on the order of 3 and 4 for breast cancer. So I think taken together, those are a cause of concern for a risk of breast cancer associated with chlorpyrifos. Also from the agricultural health study, there was a very recent study published on renal cell carcinoma with 20 years of follow-up, and they found an elevated risk of 1.7, and there was a very clear exposure response gradient. So I found that in terms of the epi evidence, those were two of the more compelling associations with cancers, and then there were scattering, sort of more limited evidence for some other cancers such as non-Hodgkin's lymphoma. There was a positive association, but in a study with very few exposed cases, 7 exposed cases. Similar for brain cancer glioma, a case control study with only 10 exposed cases, but found an odds ratio of 23. So I did find that there was some noteworthy positive associations in the epidemiological literature. And I think and then I'll leave it to my colleagues to discuss the more mechanistic and animal study literature.
Okay, do you have a preliminary suggestion about priority at this point?
Well, I think that there is very concerning evidence in the literature. However, it looks like the risk of exposure after this year would, the levels of exposure would be relatively low. So I think I'm going to go with medium.
Good, thanks. Let's go on to Dr. Lamerrill now.
Hi, thanks. Good morning again. So my overall impression is that pesticide exposure assessment in humans can be quite difficult to do because most of the studies are, occupational. In the AHS, there's a lot of co-exposures and they can be quite high. And so, residual confounding is something I was mindful of and really looking for that evidence to kind of integrate with the charges I had, which were to focus on the animals and the mechanism. And, I do agree that there was some increased breast cancer hinted at. There was a couple of studies in AHS that it seemed like it depended on what year they published it. And so I think it might need to be looked at further, but we have already heard that from our epidemiology expert. And I did note, however, that in addition to that work, there was evidence in the mechanistic literature for ER agonism across various experimental assays, including MCS MCF7 human breast cancer cell effects that were ablated by ER selective antagonists, and it was positive for ER expression or activity in 7 ToxCAS and TOX21 assays. There's also evidence of progesterone receptor binding. That literature has been less investigated, so I think elucidating whether or not the signals are ER in nature or PR in nature, if that was causally related to breast cancer, I don't believe is addressed in the literature at this time. But actually what caught my attention even more so was because of the way that there'll be co-exposures among ag workers, I particularly was interested in the epidemiology where we were looking at the effects in the highest quartile of exposure. And what I saw was that although, as we heard, the kidney was a significant elevated risk for kidney cancer, the effect size was under 2-fold increased risk, which is often kind of a rule of thumb for potential uncontrolled confounding. However, with rectal cancer, the risk of that was estimated to be 2.7 relative risk, in addition to having a trend in the AHS. And when I looked in the mechanistic literature, there was a study that indicated human colorectal adenocarcinoma cells had increased proliferation when exposed to chlorpyrifos. And so I thought that that was a bit revealing and potentially worth factoring into our assessments. As far as the animal literature goes, I would say that it's generally null. There were 5 studies, and there was only one of those studies that was positive, but it was weak in that they had increased lung adenomas in a mid-dose group, but there wasn't a significant trend. And the study data appeared to be reported a bit thinly in terms of there was no report of tumor incidence. So I thought the animal data was pretty underwhelming. As far as more depth on the mechanism, there's some mixed evidence for genotoxicity. There were both positive and negative and / null reports. And I think it would really require a more in-depth study of the quality of these investigations to decide where the weight of the evidence would land. But I would say, based on my cursory review, that it appeared to be more often positive. There, for the key characteristic of epigenetics, it's not been investigated very much. There were 2 studies of DNA methylation, and they were both null. There was 1 study of histone modifications, and there was positive associations with having chlorpyrifos exposure and HDAC changes, and this is a key histone modification in epigenetics in general. Oxidative stress key characteristic was, I think, observed in all 4 of the models that were examined that I looked at, and that included human and rat cells. I already mentioned the receptor points previously, so I won't get back into that. And the last one that I saw evidence for was the human colorectal proliferation that I also mentioned. So I think I'll stop there. And I just wanted to seek clarification for OEHHA to make sure I didn't misunderstand the directive here. So our goal is to evaluate hazard, right, and not take into account exposure levels.
Yeah, this is Carol. You're correct. You can, what you want to look at is if there's any exposure potential from whatever source, if it's residue or otherwise. But we would look at levels at a much later part of the process.
Okay. Because although Professor Crispy acknowledged that it would be mostly out of state, the rules and regulations and what happens elsewhere and even here are not things this group has control over. And so I would say that based on the colorectal cancer association with the high relative risk and the high exposure, the highest exposed of the AHS cohort, in addition to the colorectal cancer cell proliferation, as well as the hinting at the Human Breast Cancer Association with some of the ER and PR evidence out there, that I'm leaning towards high as initial recommendation. I don't feel as strong about it, so I'm really looking forward to discussing that with the rest of you.
Okay, thanks. Now let's go around to the rest of the committee and see if there are any initial thoughts, having heard from the two lead discussants. I don't see. Okay, there's Dr. Eastman with his hand up.
I can't speak much to epidemiology. As far as mechanistically, maybe there are off-target effects, but the primary effect of this is inhibition of acetylcholinesterase. And there's no reason you'd expect that to, the same sort of damage to occur to DNA or to be carcinogenic, certainly genotoxic. And apparently the animal evidence doesn't indicate really evidence for carcinogenicity. So it doesn't seem like a real strong concern for me. I'm not familiar with the Epi studies, so I can't really comment much about those.
Anyone else? Dr. Mack?
Of course, these all have to be evaluated at some point, but we're talking about prioritization for the committee, which only does a couple every year. So in terms of prioritization, I think the neurologic damage that this compound does trumps cancer to some extent, and the relative infrequency of exposure makes it go into a low priority for me.
Thanks. I heard from Dr. Sandy, who wants to clarify a point about exposure. So go ahead,
Yes.
please, Martha.
Thank you. In prioritization, so what Carol just told you is is accurate and correct for listing. You consider the toxicological and epidemiology data, and you're thinking of hazard for listing consideration. For prioritization, you may decide to use to take into account the exposure information as well in how you prioritize. I just wanted to comment on that. Thank you.
Thanks for that clarification. Now back to the committee. Any other initial comments? Not seeing any hands raised. I'll give my comment really briefly. I put this one in medium priority. You know, I echo the comments about the agricultural health study. It's a well-done study. It's large, but they've examined a large number of compounds and multiple publications over time. So it really has to be looked at pretty carefully to sort out you know, what is the most recent and relevant finding for any particular compound. It's really true that the epidemiology of pesticide exposure is exquisitely complicated. And unfortunately, as is often the case for this particular chemical, I've found the epidemiologic evidence to be inconsistent and kind of equivocal. I also didn't see any strong evidence of the key characteristics of carcinogens in exposed humans. So medium priority is where I came down. Anyone else before we see if there's a public comment? Okay, not seeing any hands. Clara, I don't see any hands raised, but are you aware of anyone else who wants to speak about this chemical?
I do not see any hands raised at this time, but just as a reminder, if you would like to provide a verbal public comment on this item, please raise your hand by clicking on the hand raising icon on the left tab of your GoToWebinar control panel, whether or not you have submitted a speaker card. And also as a reminder, if you need assistance with the virtual meeting, you can submit questions through the questions pane in your attendee control panel. And at this time, I still do not see any hands raised.
Okay, thanks, Clara. So let's go around to the committee and we'll, since there wasn't any discussion following the discussants and comments we've already heard, unless there's something else to be said, let's go ahead and poll everyone for their final views on chlorpyrifos. Okay. Seeing no other hands raised, we'll go in the same order. Dr. Lamerrill.
Medium.
Dr. Crespi.
Medium.
Dr. Bush.
Medium.
Dr. McDonald.
Medium.
Dr. Stern.
Medium.
I said medium. Dr. Zhang.
Medium.
Dr. Mack.
Low.
Low. We're not using low. Would you like medium or no? Sorry, Dr. Mack. We're not using low priority for this particular meeting. So would you prefer to characterize this as medium or no priority? You're on mute. Can't hear you. You're on mute.
We're ranking them in terms of the order in which we take them up. And there are so many others that I believe have higher priority based on the fact that there's already evidence that this stuff is dangerous and it's relatively low frequency of exposure. So on those two grounds, I consider it to be less emergent.
So would you like to call that medium priority or no priority? Those are the possibilities if you don't think it's high.
I thought we had three alternatives: high, medium, and low. So I'm choosing low. If you want to get rid of that, then I go back to medium.
Okay. So the three alternatives we were given are high, medium, and no, NO. So I think you said medium if you can't have low. Is that right?
I'm actually saying low, but if you want to call it medium,
okay.
I don't think it makes any difference because, yeah, there's going to be a lot of mediums and some of them are going to wind up being low.
Right. Okay. That's what we'll call it. Dr. Eastman.
By the time we would do this evaluation, compound would be banned and not used in California. It doesn't persist. So for me, it's a no priority.
No priority. Dr. Landolf.
Can you hear me?
Yes.
Yeah, I'll give it a medium.
Dr. Reynolds.
Medium.
Okay, very good. Now, next compound up. Dr. Zhang would like to say something. Go ahead, please.
Yes. Since we're discussing about the previous low priority was no. At the beginning, I think Dr. Winsing was explaining it to us, but I want to make a point is even though if we say no, N-O, I think maybe we should add it as no for now. It's not the no forever. Because, sometimes, the chemicals maybe currently for our committee members who are thinking is maybe very low or no priority. But I just think we should make that a little bit clear unless if I misunderstood something.
Let's see if the staff would like to speak to that comment.
Yes, this is Martha Sandy. I'll say that yes, as we heard in the presentation that began from Dr. Sun, we do continually monitor the literature, and when there is new compelling information for a chemical that you've ranked, or maybe we haven't even brought it to you, but we bring them back if there's something we think you should look at, if it's compelling. So you may say no now, but if there's new information, we may bring that chemical back to you for ranking and consultation.
Okay, good. Thanks. So we've done 2 chemicals. We are at 11:43. So according to the agenda, we were supposed to do coal dust before lunch. I'm wondering if that's okay to do that, if the committee would like to take a quick break or break for lunch now. So 3 options. Let me ask first, does anyone object to doing coal dust now and then breaking for lunch? I see no objections, so let's go ahead with coal dust. I'm actually one of the lead discussants for this this compound, this substance. So I'm going to go ahead and give my summary then. So coal dust was reviewed by IARC in 1997, and at that time it was put in group 3 with inadequate evidence in humans and animals. So, you know, coal dust is an interesting substance. I'm going to focus on the epidemiologic studies, since that's my expertise. It's been studied, exposures to coal dust have been studied quite a lot over a long time period, but mostly not with a focus on cancer. So it's relatively recently that cancer has become a topic of interest here. Some older studies did report excess mortality from lung and stomach cancers among coal miners. But even in the more recent literature, most of the data available are on non-malignant respiratory disease and injuries, not surprisingly. So now, turning to recent studies, there are 2 large studies of occupational cohorts of coal miners in the US and the United Kingdom that are notable because they feature long-term follow-up and quantitative assessment of exposure to coal dust. But there's a complication here. In fact, through all of these studies, whether epidemiologic or toxicologic, and that is that coal dust isn't a pure substance. It tends to be mixed in reality with a smaller or larger amount of crystalline quartz, which is a group 1 carcinogen that causes lung cancer. So in both of these cohort studies, there were, in addition to the quantitative assessments of dust exposure, efforts to control for potential effects of the admixture of silica dust, of quartz, in the coal dust. In the US study, the most recent analysis of that reports data for lung cancer did show a statistically significant increase in lung cancer mortality with increasing dust exposure after controlling for silica. So that is a exposure response trend. However, the UK study didn't find any notable excess of lung cancer or any trend. Again, after controlling for silica. Both studies also looked at stomach cancer. In the US study, the most recent publication didn't report any data, but in the prior publication, there was no notable excess of lung cancer and no trend. Likewise, in the UK study, no notable excess and no trend. Those studies, although they're quite large, didn't report data for other cancers. So for that, we have to look at case control studies. There are quite a number of those from different countries. I'll just highlight a few. Case control study of lung cancer in Polish women only did find a significant excess of lung cancer with self-reported exposure to coal dust. Similar study in the US that included men and women found a significant excess in men, but not in women. A few other studies looked at coal dust exposure in connection with cancers of the larynx and pharynx. One notable study was a case-controlled study in France that found a positive association with cancer of the larynx and a stronger statistically significant association with cancer of the hypopharynx. Another large multi-center study of in Eastern Europe also found similar exposures that were positive and statistically significant. Both of those studies are notable because exposure was assessed by experts based on complete occupational questionnaires, so their exposure data are a bit better than simple self-report. An earlier French study also found an excess of combined cancer of the larynx and hypopharynx. And one other study in Serbia looked at cancer of the oropharynx, but found no association. A few other cancers have been looked at in case control studies. I note significant excesses of multiple myeloma and acute myeloid leukemia in one study each. I'll just briefly mention the studies in animals, but defer to the experts in that area. It looks like has been, since the IARC evaluation, one long-term carcinogenicity bioassay, which found no lung tumors in animals treated with coal dust and none in the control group. Coal dust used in that experiment had a very low silica content of less than 0.1%. The second animal study doesn't appear to be a true cancer bioassay, and it had kind of a strange design because the coal dust involved various admixtures of silica, and there was a significant difference in the incidence of lung tumors between the treated animals and the control animals, but it didn't seem to be related to the mixture of silica. Moving on to the mechanistic data, just really briefly, I didn't see any genotoxicity data in exposed humans, but there are positive findings of chromosome aberrations and sister chromatid exchanges in human and mammalian cells in vitro, and then mixed findings in some mutagenicity studies involving other test systems. I noted evidence of oxidative stress in exposed humans and increases in TNF-alpha in bronchoalveolar lavage fluid from treated rats. For me, this one with kind of equivocal epidemiologic evidence and not compelling mechanistic evidence and limited potential for exposure in California falls into the medium priority category. And now we can move to the second discussant, Dr. Landolf.
Thank you. Can you hear me okay?
Yes.
Yeah. Okay, good. Thank you. Yeah, it's interesting. I would have expected more than that for such a mixture of substances. I was thinking of benzpyrene when I looked at this, but I agree with your assessment of the epidemiological data. And the animal data is really somewhat sparse. There was that one table of data, table 9, and it showed, they just looked at the percent of animals with tumors, and it was benign, malignant, and total. And they do have benign and malignant tumors. The highest goes up to 72.7% of malignant tumors and 66.7%. The others go down from that towards zero eventually. So that is not a dose response or anything like that, and they didn't report the tumors, so they can't do good statistics on it. So it's really, I would say that's a positive, but it's only like a 1-point set of data. It's not very good. The other data, yes, it's genotoxic. It induces chromosomal aberrations and SCEs in human lymphocytes, induces sister chromatid exchange in Chinese hamster ovary cells. if you nitrosate the extracts of this coal dust, then you get positive in 3 Ames strains. Induces oxidative stress. Long-lived radicals and coal dust recovered from the coal miners' lungs and lymph nodes, which was interesting. And they find higher 7-hydro-8-oxodeoxyguanosine, so that's another marker of oxidative stress, as was previously mentioned. And induces chronic inflammation. They say it causes immortalization, but that's a misprint. It really induces, they say, cell transformation, which means a morphologic transformation, which is a surrogate for carcinogenesis in vitro. So I would say, yeah, it's kind of medium to no, probably medium, I guess. It's just a very sparse database and not that much has been done on it yet. I hate to see OEHHA go through and make a huge hazard ID document on this with such a paucity of data. So I'm probably leaning toward probably no at this point. Thank you.
Other comments from the committee? Dr. McDonald, you're trying to say something?
Yes, thank you. The lead discussants, I didn't hear any discussion about exposure potential in California. I did see from the OEHHA document that there could be some occupational exposures from rail transport and shipping. I guess there's one coal plant in the state, but I'm not aware of any active coal mines. So did any of the lead discussants find much on exposure in California? Thank you.
I did not. I presume it's quite limited, and of course, you know, the use of coal is declining. Probably not fast enough. Other comments from the committee? Dr. Mack.
For the record, I actually, just as I did last time, this stuff causes pulmonary I'm sorry, I'm blocking on the word, inflammation and a bad disease. And the exposures are relatively small. So I actually think this one deserves low priority for formal evaluation. Of course, again, it will have to be done sometime, but there's so many others with higher priority.
Thank you for that, Dr. Mack. Other comments? All right, looks like there are none. So let's proceed to poll the committee on coal dust. We'll go in the same order. Dr. Lamerrill.
No.
Dr. Crespi.
I'm also going to go with no.
Dr. Bush.
No.
Dr. McDonald.
No.
Dr. Stern.
No.
Dr. Zhang.
No.
Dr. Eastman. You're on mute. Mute.
I go with medium. Find it interesting, although I don't think there's too much data out there, but be interesting.
Dr. Landolf. Can't hear you. You're muted. You're still muted. Can't hear you.
Medium.
Medium. Okay. Dr. Reynolds.
No.
Dr. Mack, I think you already said no. Do you stay with that?
Oh, yes.
Okay. And I was on medium, so I think the no's have it. All right. We are caught up on the agenda, so I think this is a good place to stop for a lunch break. So let's reconvene at 1 o'clock.
Okay.
Good to see you, Tom.
You've retired?
I have formally retired, but I'm still involved professionally.
Makes sense.
I figure I can do almost anything as an emeritus professor I can do as a regular professor. But I have a lot more. What's that?
Say it again.
I can do almost anything as an emeritus professor I can do as a regular professor. So why not?
Yeah.
Hi there. I just wanted to remind you we are still live. Okay, but anyway.
Thanks, Martha.
Carry on.
So Wendy's moving to UCI.
Oh, she is. Oh, interesting.
Oh, really? Like, hi for me.
I guess we can't talk anymore. People are all coming on. Hi, Peg.
Okay, we want to do a quick audio test here. just to make sure we can verify that we can hear everyone. So let's just start at the top. Dr. Mack, do you want to just say hi? And you just remember, have to unmute yourself. David, let's try you. Can you say hi, please?
Hello again.
Perfect. Thank you. Peggy?
Hi.
Thank you. Thomas?
Thomas McDonald, yes.
Thank you. Mariana?
Hello, can you hear me?
Perfect. Yes, thank you. Jason?
Jason Bush.
Thank you. Michelle?
Good afternoon.
Thank you. Catherine?
Over here.
Joseph? Thank you. Dr. Loomis?
Hi.
Thank you. And Dr. Zhang?
Hi, everyone.
Perfect. And let's go back to you, Dr. Mack, please. Can you just say hi? We just need you to unmute yourself, Dr. Mack, and just say hi. Okay, it is now 1:01 p.m. So shall we go ahead and get started, Dr. Loomis?
I think we should. So let's go ahead then with the, we reconvene the second part of the scientific discussion. Welcome back, everybody. Hope you had a good break. Before we start with the next substance, I'll just remind the committee that we have written comments on all of the substances on the schedule for this afternoon, which you may want to look at. Having said that, let's go ahead with DECA BDE. So for that, Dr. Eastman.
I need to recuse myself from this particular chemical because of a potential conflict of interest. So I'll be sitting in, but won't be making comments or voting.
Okay, I won't call on you. Any other business before we go ahead with this discussion? Nope. Okay, so lead discussant, Dr. McDonald, please go ahead.
Yeah, thank you. I want to thank OEHHA for pulling together all of the papers and the nice discussion. I also want to thank the public commenter for presenting written comments on decabromo-diphenyl ether, which is a part of the class of the PBDEs, the polybrominated diphenyl ethers. This is the fully brominated version of that class. It's a flame retardant used in plastics and high impact polystyrene, also in rubber. So it's in lots of electronics, textiles, building materials. It's found in human breast milk and blood as part of the California biomonitoring program, detected in about up to 40% of people, depending on the study. Most cases, the levels would be considered very low, in the low nanogram per gram lipid. But some populations, such as firefighters, have been shown to have somewhat higher concentrations, up near 100 nanogram per gram. DECA BDE is found in house dust and in foods, so exposure is very low but widespread, and it's likely decreasing over time. As you probably read, it was phased out of production in the US in 2013. There's still some TSCA reporting for current years. Some public comments from the American Chemistry Council's North American Flame Retardant Alliance was kind enough to indicate that some of the releases out of 2018 were actually transfers to landfill. And OEHHA was nice to provide us with a proposed rule from US EPA in 2019 that's proposed a prohibition of DECA except in some very critical products such as aircraft, hospital curtains, and plastics recycling. I'm not sure what the status of that proposal is. This compound does break down in the environment to some of the lower brominated congeners of the PBD class, but it's not clear what percentage of the lower brominated that are measured in people come from DECA or come from use of other flame retardant mixtures. Half-life in people is about 15 days. I won't focus too much on the epidemiology. I'll leave that to Dr. Stern, but there were 3 human studies. One on papillary thyroid cancer in some gene variants showed very high odds ratios. I would note in that case control study, exposure was based on house dust and blood paired samples. But if you look at the distributions of those concentrations versus cases and controls, those distributions overlap quite significantly. So there was ability to compare high and low exposures, but they're not that far away from each other. Same with the other hospital case control out of China. 14 PBDEs were measured, and I'll let Dr. Stern get into the details, but in that case as well, the blood levels of PBDEs among cases and controls, those distributions overlapped quite substantially. With respect to animal carcinogenicity, just for completeness, I'd say that there's an early cancer bioassay that wasn't in the prioritization document. Back in 1975, Casiba dosed DECA BDE up to just 1 mg per kg for 2 years, finding no tumors. This actually studies the basis of US EPA's oral reference dose for this compound. But as you'll see in the later NTP 1986 studies, the doses that were used there were over 2,000 times higher. So you can see why the Casiba study should be discounted. There were 4 cancer studies of DECA reported by the US National Toxicology Program in 1986, 1 in male rats and 1 in female rats, and then of course male and female mice. DECA PBDE is not acutely toxic, and it's well tolerated to very high dose, and that's probably because only about 1% is actually believed to be absorbed according to the NTP in those studies. The doses given to the animals in the NTP studies were extremely high. In the male rats, for example, up to 6,650 mg per kg, females 7,780 mg per kg, and then in the that was mice, and then the rats were 2,240 mg per kg and 2,500 mg per kg as the top dose. Those are very high, but would kind of exceed EPA's current carcinogenicity test guidance that indicates, quote, the highest dose tested need not exceed 1,000 mg per kg per day, unquote. But nonetheless, in the male rats, there was some hepatocellular adenomas, benign tumor that was increased in a dose response fashion through both doses and by trend test, but there was no corresponding increase in carcinoma. There was also pancreatic and acinar cell adenomas, also benign tumor in the high dose. Female rats, survival was not appreciably different from controls. Again, there was statistically dose-related increase of adenomas. There were 2 carcinomas in the mid dose, but none in the high dose. And thus the malignant tumors did not show a dose-related trend. In the male mice, survival of the male really was quite decreased early on in the control group due to fighting. But by the end, survival was pretty good and not statistically different from controls at the end. There were increases of both benign and malignant tumors. However, the incidences only reached statistical significance in the mid-dose group for the hepatocellular adenomas and carcinomas combined. And benign, malignant, and benign and malignant combined were not significant by trend tests. There also was suggested increases of thyroid cell adenomas and carcinomas combined, with an incidence of 0 of 50 in the control group versus 4 of 50 and 3 of 50. Female mice showed no increases in cancer relative to controls. With respect to other information, the lower brominated PBDEs, specifically the technical grade penta PBDE mixture, is on the Prop 65 list. As I said earlier, it's unclear if DECA is metabolized to the same congeners in the PBD product that was tested for carcinogenicity. And there's also some breakdown of DECA in the environment to lower brominated species, but that's really not a basis for prioritization. The Penta group, the Penta BBD, the listed carcinogen also, it caused liver adenoma and carcinoma combined in both rats and mice in both sexes, as well as some thyroid adenoma and pituitary gland adenoma in the male rat. Gene tox, it's not mutagenic in bacteria mammalian cells, but there is mixed results from mammalian cell clastogenic effects, but on generally negative, but there are a few positive findings in there. It's a number of studies on receptor-mediated effects, such as PXR, also thyroid hormone disruption studies in mice at high doses, and then also some other receptor cell modifications with estradiol antagonistic effects. Okay, so I'll leave it there, and I would say overall, I would characterize and prioritize this as medium.
Okay, thanks. Dr. Stern, on to you.
Thank you for that introduction that provided all the background information. So I'm going to add that what struck me with this chemical is that the home environment is one of the main sources of exposure, mostly indoor dust, and that there's studies that have shown a good correlation between household dust and biomarkers of exposure in humans. So that means that the exposure is pretty ubiquitous. At the same time, it means that the assessment in epidemiological studies is challenging because of where you find this chemical, and also because the short life is relatively short. The half-life is relatively short. What I want to emphasize is that some of the biological studies have highlighted that one of the potential mechanisms that the impact that it could have in humans is by disrupting thyroid hormones. And this seems to be one of the main concerns from a human perspective. So as it has been mentioned, there's been 4 epidemiological studies that have been done. So the literature is very scarce in terms of the human effects. Of these 4 studies that have been done since 2017, so the literature is pretty recent for this compound, they're all case control studies. There are no cohort studies that have been done. One of the studies is population-based and 3 are hospital-based. 2 of the studies are focused on thyroid cancer in the US, 1 on breast cancer in China, and 1 on pediatric acute lymphoblastic leukemia in California. Of the 4 studies, 2 reported positive associations, and I'll go into a bit more detail, 1 in thyroid cancer and 1 in breast. 1 reported an unexpected inverse association and the other a null association. So the data is fairly limited. And I think part of the concern is the exposure assessment. So some of the studies use household dust, and some of the studies look at serum detection of this compound. So as mentioned before, there's 1 study that showed a positive association. This was a study done in North Carolina looking at papillary thyroid cancer. And they use both. They use household dust and they use serum measurements. Now, they did not detect the BDE 209 compound in the serum, so they did not provide data for association with the serum sample, but they did provide data for the household dust sample, and they found a significant positive association, showing that individuals who had high levels of exposure had almost more than two times the risk of developing papillary thyroid cancer. The downside is that this was a fairly small study. There were 70 cases and 70 controls. They did some sub-analysis looking at a specific mutation in the tumors, and they found that the association was stronger among those that did not have a mutation in the BRAF gene. So the other positive study was in breast cancer, as mentioned before. This was done in China. This was a little larger study with 209 cases. This was a hospital-based study. And here, what they did is they measure adipose tissue. So in the cases, mostly it was breast tissue. And in the controls, it was a mixture of breast and abdomen tissue. And they found that there was good correlation in other studies between the abdomen, the amount present in abdomen fat, tissue, and breast. Here they did see a dose response between across different tertiles for exposure and with a significant trend. And then they did analysis adjusting for other BDEs, and the positive trend remained. So this study is supportive of an effect or at least an association between this compound and cancer risk. The other good thing about this study is that they use adipose tissue, which is able to capture a longer period of exposure than the serum samples or the dust. Now, there were two other studies, one in thyroid cancer done here in the US, in Connecticut, that did not find a positive association. What they mentioned in that study, this study did not look at dust samples, they look at serum measurements. And one of the things that the authors mentioned is that because of the short half-life of the compound, the serum measurements that are done at one point in time may not be sufficient to capture the exposure. The other thing they noted is that among the participants, which were all women in Connecticut, the levels were significantly lower than the rest of the country, and they did not have a fairly wide range of exposure, so that may explain why they were unable to find an association. The study done in California for pediatric ALL did use household dust samples, and this study was negative. So what I found compelling about this compound is that particularly the biological effects on the thyroid hormones is because we do see rising rates of thyroid cancer here in California among females, which started going up in the 2000s and have pretty much peaked around 2011. In California as a whole, they have stayed the same, but if you look at data for the Bay Area, the rates keep going up. So the finding of that one study on thyroid cancer, I thought was intriguing. However, there are not other studies, so the evidence is limited for humans. Now, as mentioned before, the animal evidence is also limited, mostly suggestive of a potential effect in hepatocellular adenomas. There's no animal studies that support a role for thyroid. There's just few studies. What drew my attention was that in looking at the mechanistic evidence, there are some studies that support that this compound may modulate effects via the thyroid hormone. So that goes along the lines with the epidemiological study found. So overall, I think based on the limited evidence for humans and the limited but suggestive evidence for the mechanistic studies and animal studies, I would say that the priority is medium for this compound.
Thanks for that. This is Dana Loomis. I'm back. I don't know if anyone noticed that I disappeared, but the power went out where I am. And so I'm just on the phone right now, and I can't see any of you. So not being able to see you, I won't know if anyone raises their hand to comment. So I think what I'll do is just go down the list, call on each of you in turn.
Dana?
Yes.
Hi, Dana. Hello,
Yeah.
Dana. This is Lauren Zeiss. I'd be happy to assist you, letting you know whose hands are up.
Great. That
If
would
you'd
be
like.
perfect. So, is anyone's hand up?
I don't see anyone's hand right now. Okay, Joe Landau.
Yeah, there you go. Okay, can you hear me now? Yeah, okay. Yeah, this sounds very similar to TCDD. It binds to the AH receptor. It's not really very genotoxic, maybe a little bit of oxygen radicals produced. I agree with Mariana. I would mechanistically put it in the TCDD-like class and give it a medium priority. I think that's a reasonable thing to do for this compound.
Okay, Dana, Dr. Mack's hand is up.
Okay, Dr. Mack, please go ahead.
Dr. Mack, could you please turn on your speaker?
That I'll go along with medium also, but with thyroid cancer, you'll have to worry about the effect of ultrasound examinations in doctors' offices. There's a lot of evidence that the increasing risk in California, as well as in Korea and Japan, is due to the high prevalence of doctors' examination, finding very small tumors that are unlikely to actually progress. But given the evidence and given the interaction with genetics, I'll go for medium also.
Okay.
Thank you. So anyone else?
Don't see any other hands, Dana.
Okay. I also would put it in medium. You know, I found the human evidence less than compelling, but the exposure is widespread, and you know, I noted also the structural similarity to several other carcinogens, which kind of elevates it for me. As far as I know, we don't have anyone from the public who's requested to speak, but perhaps Clara could verify that.
That is correct. At this time, there are no hand raised, but just a quick reminder, if you would like to make a public comment, please go ahead and raise your hand at this point. And there are still no hands raised at this point, Dr. Loomis.
Okay, good. So we'll just go down the list then and complete the roll call. I know some of you have already spoken, but I may have missed part of it. So I'll just call on everyone. Dr. Bush, where do you put it?
Medium.
Okay. Dr. Crespi.
Medium.
Okay. Dr. Eastman.
I've recused myself.
That's right, forgot. Thank you. Dr. Lamero.
Medium.
Dr. Landolf.
Medium.
I said medium. Dr. Mack. I think you already said medium. Medium, okay. Dr. McDonald.
Medium.
All right. Dr. Reynolds.
Medium.
Dr. Stern, I think you said medium. You still there?
Medium. Yeah, medium.
Okay. And Dr. John.
Medium.
Okay. Very good. I think we have consensus on medium. So let's move on down to methyl bromide. The lead discussants are Dr. Eastman and Dr. Reynolds. So Dr. Eastman, let's go ahead with you.
Okay, thank you. I didn't realize OEHHA had summarized things for us, so I went through and did my own summary. So this is pretty independent evaluation. First thing I would indicate that methyl bromide was fumigant, was used pretty extensively in California, but was phased out, began to be phased out in 2005, I believe, because of concern about ozone depletion. It was allowed with exceptional authorizations, but I believe those have also been phased out in California. So its use is probably very, very little or none at all. It is a moderate to highly toxic chemical. It's an alkylating agent, methylating agent, and it's structurally similar to bromoethane and possibly other haloalkylane carcinogens. As far as genotoxicity and mutagenicity, it's pretty consistently positive in vitro studies, causes DNA binding, DNA adducts, mutations in bacteria, and different types of damage in mammalian cells. It becomes, when you go in vivo, it's not nearly as clear cut. There is DNA binding that's been seen, adduct formation. However, there was not an increase in mutations seen in transgenic mice assays, which is one would have expected. It's kind of unusual. It's shown some mixed results in NTP studies. The short-term studies showed positives, but the longer-term studies, no increase was seen for both micronuclei and sister chromatin exchanges. And there was one study in which a non-significant increase in HPRT variants and oral micronuclei was seen in one small human study, but did not achieve statistical significance. Things become much more cloudy when we get to the animal studies. There are, first of all, there are 2 quality rat studies and 2 quality mouse studies. It was negative at all sites in the male and female mice studies. It was negative at all sites in the 2 female rat studies, negative at all sites in 1 male rat study, and positive for pituitary gland adenomas, but negative at all other sites in the other study. Now the one study wasn't in the materials that was given to us, but it was outlined in the IARC evaluation that took place in, I believe, 1999. Let me respond. In the document we received, they highlight a report from Dance et al. In 1984, in which increases in forestomach tumors were reported in a 90-day study. High incidence, these are like 60 and 70% of the animals were reported to have forestomach tumors. This would be very unusual because it was only a 90-day study. And you all know tumors generally take a long time to develop. This was questioned. The pathologists from the National Toxicology Program went out, reevaluated the slides, and concluded these were hyperplasias. So in my mind, both biologically it doesn't make any sense, and the follow-up study indicated that study is not really credible. And there was a follow-up study that went for about a year and didn't see any tumors in the forestomach. They did see hyperplasias on oral administration. The other studies were inhalation studies. So in general, the animal studies are largely negative, considered that way. The human epidemiology, Dr. Reynolds will probably do a better job of this than I, but let me start with, since she actually did some of these studies, understand. But I'll give you my sort of summary. There are 2 studies of childhood cancers Dr. Reynolds was involved in. One was an ecologic study, one was a case control study. Both did not see any increases in combined childhood cancers, leukemia, or brain cancer. There are other reports of sort of increases. Most of these are not statistically significant, or they don't have dose responses or other things in testicular cancer, gastric cancer, breast cancer, renal cancer, and I can go through them if you like in more detail. The one that's particularly interesting, or so most interesting, is the prostate cancer. There are initial results from an agricultural health study which reported a significant increase in exposure-related association between methyl bromide exposure and prostate cancer. However, and that was followed up by some other studies from Mills and Yang that saw a modest increase, particularly, although these, again, are sort of not statistically significant, but suggestive of trend, I believe. And there was an increase seen by Cockburn et al. It saw a significant increase, but there was no, the trend was not significant. The agricultural health study and the follow-up, which was published in 2012 by Berry et al., the original association between methyl bromide and prostate cancer did not persist in the follow-up study, so it was, they did not see a sort of significant trend there. There was a study which was done by a group called Budnick et al., and they looked at a meta-analysis of the 3 earlier positive studies, and they reported a meta-odds ratio of 1.2, which was not quite statistically significant. P-value is 0.076. But since the one study would be replaced by the more recent Berry study, it's likely that association would undoubtedly be weakened. I guess so. In overall, my assessment of this, I would put this as a medium concern. It's clearly mechanistically of a concern because of the alkylating properties in the adducts, but the animal studies certainly don't seem to be very strong, and the human studies are mixed suggested, but I don't think any of them in and of themselves are particularly strong either. But I'll look for Peggy to kind of correct me on the epi studies. Thanks.
Okay, thanks, Dr. Eastman. So let's go on to Dr. Reynolds then for another comment.
Okay, thank you. You did most of my work for me by going through the epi studies, and I appreciate that. I'll try and be brief. My view of the epi literature is there's really 2 main sources of epi evidence for cancer risks associated with methyl bromide. The federally sponsored, multi-agency, very large agricultural health study, which is something that was initiated back in 1993 with follow-up through 2015, and then several studies from California spanning the 90s up until just 2019 that you have gone through in some detail. So Dr. Crespi did a lovely job of telling us some detail about the agricultural health study. Just briefly, it was a large, carefully designed prospective cohort study, which is considered to be one of the great advantages for epidemiologic studies. It was a cohort study of farmers and pesticide applicators and their spouses in both Iowa and North Carolina. And although pesticide use was initially based on questionnaires, the cohort members were actually selected based on applications for restricted use pesticides in each of those states. And given their occupations, are likely to have been able to fairly well report their use of this particular pesticide, not to mention all of the other ones that were studied. So with nearly 90,000 participants, active follow-up through 2015, extensive covariate information, and several intermediate nested studies, the AHS has been a really valuable source of information for many pesticide-associated health risks. For methyl bromide, they reported significantly elevated cancer risk for 2 cancers, as I think you mentioned, stomach cancer, with evidence of dose response with a relative risk of 3 for the highest quartile, but based only on 15 exposed cases, and prostate cancer in the highest categories of use, which were based on 6 and 5 cases respectively in the 4th and 5th quartiles of use, and evidence of dose response. They looked, but did not find higher cancer incidence for several other cancers, including kidney, NHL, leukemia, Hodgkin lymphoma, oral cavity, rectum, lung, bladder, or melanoma, nor in fact for prostate cancer in the follow-up study, although they did report suggestively elevated risk among those with a family history of prostate cancer. Analyses of cancers among the spouses, which is an interesting group, did not report specifically on methyl bromide, although they did find elevated breast cancers with chlorpyrifos, which we already talked about. So there were these small nested case control studies in the Central Valley, a couple of the UFW farm worker cohort, which found no cancer associations for methyl bromide use in prostate cancer, but a suggestive elevation for stomach cancer at the highest levels. And then you mentioned some of the geographic information studies. These were based on California's very unique pesticide use reporting system and residential patterns in California. And these studies found very mixed results for people living in areas of high methyl bromide use. So they found a higher incidence of prostate cancer for residents at diagnosis. I think this was the Coburn study, and no elevation in breast cancer risk. And as you mentioned, my own studies of childhood cancers using the PUR database found no elevation associated with maternal residence at birth or the child's residence at diagnosis. So in general, human health studies have had the opportunity to study risk in cohorts with and areas of high agricultural pesticide use, but with mixed results, due in part probably to small sample sizes, as is the case for the UFW studies, or indirect measurements, as is the case for population studies using those indirect exposure estimates based on nearby pesticide use. So I think the most robust evidence really does come from the large agricultural health study. Granted, as the exponent reviewers pointed out in public commentary, the relatively small proportion of applicators reporting methyl bromide use, which was just under 15%, and the small number of specific cancers of interest could result in what they refer to as sparse data bias. But and in addition, there are always problems of multiple testing in these kinds of studies, and the agricultural health study looked at many cancers and many pesticides over time. There does remain, nonetheless, some evidence for elevated risk of specific cancers among pesticide applicators, and those are the kind of people for whom exposures may still persist under the EPA critical uses criteria. So, while there's some human health evidence for cancer risk, hopefully the phase out in 2016, continuation of that from the Montreal Protocol and the Clean Air Act, will result in future declining population exposures for Californians. And I would agree with you. I would classify this as medium for CIC review. I was going to say medium to low, but we don't have low anymore. So I'll go with medium. Thank you.
Okay, thanks a lot. Now, Lauren, if you can help me identify anybody else from the committee who'd like to speak now.
Yes, Dr. Lamera.
Yeah, I just wanted to point out that when I looked for tissue-specific mechanisms based on the AHS evidence, I did find that there was DNA adducts found in stomachs. I believe it was rats, methyl guanine, but I haven't seen anything for the prostate that's been evaluated positive or negative mechanistically.
Okay, thanks. Anyone else?
Tom McDonald, Dr. McDonald.
Yeah, I just had a question for Dr. Eastman. I noticed in the methyl bromide industry panel comments, there was another set of bioassays that were done at the ministry, a Japanese Ministry of Labor in 1992 that were also negative. Were those summarized in your analysis?
They were. I didn't have access to those actual studies, but they're summarized in the IARC evaluation. So they are the ones which were negative. It was an inhalation study in mice, and they were both negative in male and female mice. In the rats, they were, the females were negative. The males were negative except for an increase in basically pituitary gland adenomas. And so I think the idea was because there was a similar study done out of the Dutch health ministry, in rats, and that didn't see an increase. So you got two high-quality inhalation rat studies. One saw an increase, the other didn't. So they tended down, dismissed those results. But there was, in IARC, reported an increase in one of the tumor sites.
Thank you.
Anyone else?
Dr. Stern.
I just wanted to add two comments that caught my attention when reviewing the epidemiological literature in case they're helpful. I was puzzled by the finding from the agricultural health study for prostate cancer because they had a decent size in their 2003 study where they found a dose response with a positive, a significant trend. And then when they added more men to their study with the Berry 2012 study, then the study was null. There was nothing. So I that kind of caught my attention. But then I look at the comments that were offered by the investigators, and one hypothesis that they suggest was that the men that were added, the new cases that were added in the newer study had used less of the methyl bromide because it was starting to be phased out, or for some other reason. So they speculate that perhaps with the addition of the new cases, there could have been kind of a dilution effect of the association because these men were not as exposed as the previous study with the men that were diagnosed earlier in the cohort. So I just wanted to add that comment. And the other comment is that the positive study by Cockburn, which was done using the GIS database that Dr. Reynolds explained, they did find a positive association when using residential exposure, but then they also did a sub-analysis where they look at the exposure at the address where the men were living when they were diagnosed, because some of them may have moved after diagnosis. And when they did that, they did find a dose response with a significant trend. So I agree with Dr. Reynolds that there's some challenge with this type of assessment. Is not as accurate as what the agricultural health study uses, but I just wanted to add that comment that adds a little bit of, concern about the potential effect on prostate.
Thank you. Anyone else?
Dr. Landau. Hi, your mic's not on, Dr. Landau. Claire?
Yeah, it's not me. Okay, yeah, I think, there's some epi data here. There's far less animal data, but not that many tests have been done. There's a reasonable amount of gene tox data. And I have to point out that carcinogenesis, if you look at the slopes of the dose response curves, it spans a fold. So this might fall toward the weaker end. I think we need more data on it, but I'd be comfortable with a medium at this point, mainly because alkylating agent, and there are 2 alkylating agents on there already.
Other comments?
No other hand. Oh, Dr. Reynolds.
Oh, never mind. I was just going to comment in that there was an indication that Dr. Stanley might have wanted to make a comment in response to my comment about declining exposure.
Sure. Thank you very much. This is Dr. Sandy. Just a really quick, just to follow up on what Dr. Reynolds had said about exposure, as was discussed in the summary. The critical uses exemption and the quarantine and pre-shipment uses are still operative right now. So for the most recent use, year of use, 2017, we have data suggesting 1.8 million pounds were used in California for pre-planting soil fumigation and post-harvest fumigation of commodities and for treatment of certain plants and trees. Thank you.
Thanks for that information. That's very helpful. I just have a brief comment. I largely find the epidemiologic evidence inadequate with just one indication of positive association with stomach cancer in the AHS and one or two positive associations with prostate cancer, depending on how you interpret the change in the results of the AHS. The animal data appear inadequate to me too. So in spite of the agent being genotoxic, I would have put it in low priority if we had low priority. So I guess I would, at the moment, probably stay with medium. So, any other members of the committee would like to speak before we check on public comments? Sounds like there's no one. So if that's correct, I understand that there is one member of the public who's asked to speak. Clara, if you could verify that and allow that person to speak. If they were there, that would be great.
Yes, we have a Tracy Heinsman who has their hand raised. So Tracy, I'm going to go ahead and unmute you from my end. You are, there you go. Go ahead, Tracy.
And let me remind you, before you start, sorry, let me remind you that your comment is limited to 5 minutes.
Yes, thank you, Dr. Loomis. Understood. My name is Tracy Heinsman. I'm the Executive Director of the Methyl Bromide Industry Panel. We submitted public comments, which it appears that several of the committee members have reviewed. I just want to make a couple of points given the discussion. I do want to make it clear that in terms of exposure, the critical use exemptions, they were eliminated or basically phased out in 2015. The last year that the United States applied for critical use exemptions through the Environmental Protection Agency and the State Department was 2015. They have not solicited any critical use exemption requests from the applicator or user community since then, and there is no indication that they would start those again. The only uses which continue are what we call quarantine and pre-shipment uses, which are allowed under the protocol. The vast majority of those uses are in post-harvest fumigation in industrial settings, primarily in ports, when commodities are coming in or they're being exported out. There's a very limited pre-plant soil quarantine use for nursery stock, and that is primarily concentrated in Siskiyou County in California, where strawberry nursery plants are grown in greenhouses. I do note that from Dr. Sun's earlier presentation in her chart, when you look at the exposure column, she indicates that, occupational exposure, it says very limited, and that there is really no general public consumer residential type exposure at this point, given the limited uses of the chemical. The other, we would recommend that this have no priority. We understand that there is some concerns or some points were made about animal data here and also about the epi studies, but there is one important point I wanted to make that was not included in any of the discussion, including the OEHHA document, that is the Environmental Protection Agency's Office of Pesticide Program, which is recognized as an authoritative body for purposes of the OEHHA's 2004 policy on prioritization. And methyl bromide was evaluated for registration review. It had a complete human health risk assessment done in December of 2018, and then in September of this year, the EPA put out what is called its interim decision on registration review. In both the risk assessment and in the recent September document, EPA concluded it was not likely to be carcinogenic based on the long-term in vivo studies that Dr. Eastman mentioned, and also EPA's review included review of epidemiological data. There were 44 studies that were reviewed. Some of them are part of the analysis that was done by the OEHHA staff, and EPA found that those studies were not, did not show a sufficient association to change its view that there was no evidence that methyl bromide causes cancer. So I just wanted to point that out because in the 2004 policy document, it does make a comment that when there is a recently reviewed determination by an authoritative body and that body finds insufficient evidence of carcinogenicity, the document does say it's unlikely that a chemical in that category would be proposed for the CIC review. So I don't know if it was so new that the staff wasn't aware of it and it maybe didn't show up in some of the other reviews that were done, but I wanted to point that out. And then my only last comment would be that we do appreciate the opportunity to submit our written comments, and we're glad that the panel reviewed them. And also we would like to thank you for your service on the committee. You know, it is time consuming, and we appreciate that that you are devoting your time to this and that you all have the highest credentials for reviewing toxicology and epidemiology data. And with that, I will take any other questions that anybody might have. I do believe that this is a chemical that has very low exposure potential.
Sorry, your time is up.
Okay, thank you.
Okay, thanks. Thanks for your comment. Is there any other public comment?
There is no other public comment at this time.
Okay.
Dr. Loomis?
Yeah.
Sorry for interrupting. Martha Sandy is available to make a comment on.
Yeah. I was going to ask if she wanted to address that.
Yes, thank you. The US EPA's document, a review of methyl bromide, there are actually two documents. One is proposed and one is draft. And so for authoritative bodies, we are looking for final documents from authoritative bodies.
Okay, thanks for that clarification. So we have time for more discussion by the committee. And again, Lauren, if you can help me identify if anybody would like to speak, that would be appreciated.
Sure. Dr. Eastman's hand is up.
I have a question,
please.
probably addressed to Martha Sandy, Dr. Sandy. It seems to me that was helpful to know how the OEHHA dealt with sort of authoritative body determinations from EPA. Let's say that the committee goes forward and gives this some ranking, either medium or high or whatever. If the EPA finalizes their document subsequently, would you use that information to revise your priority, or would you just go forward on strictly what the committee has recommended?
We do take into account new information as it becomes available on chemicals, even after we've consulted with you and they've been ranked.
Okay, thanks. Other comments from the committee for the discussion?
Not seeing any raised hands.
All right, let's go ahead and poll the committee then, if there's no further discussion. Dr. Bush.
Thank you. Medium.
Medium is a low, medium.
So who is the second speaker there? I'm sorry, I can't see you.
That was Dr. Mack.
Dr. Mack.
Okay, Mac. Okay, so medium. Dr. Crespi.
Medium.
Medium. Dr. Eastman.
Medium.
Dr. Lamero,
Medium.
Dr. Landolf.
Medium.
All right. Dr. McDonald.
Medium.
Thank you. Dr. Reynolds.
Medium.
Dr. Stern.
Medium.
Dr. Jung.
Medium.
And I said medium. So that finishes that compound. I see we've been going for about an hour. We have 2 substances left plus some remaining business, which looks like it would not take very much time. I'm wondering if this would be a good time to take a short break before we finish up the rest of the business. Would anyone object to taking about a 5-minute break?
Sounds good.
We're seeing thumbs up across the committee.
Okay, and with luck, maybe the power will come back on here, but I'm not counting on it. We're having a bit of a storm up here.
Okay.
So we'll come back at about 2:03. Thank you.
Okay, Dr. Loomis, it looks like we can see you again, but maybe just stay on the phone audio just in case you lose power again.
Yeah, that's a good idea. I'm using my phone as a hotspot at the moment. So there's no telling how long that'll last. So let's try to do that. And if I get cut off again, I'll try to call in with the phone.
Okay, it looks like it's about the time where we'll get started again. So if we could have all the panelists to turn on their webcams again, please and thank you.
Okay, I think everyone is here. Don't see Dr. Mack. Let's give Dr. Mack another minute. I'm still hoping Dr. Mack can join us, but maybe we should go ahead with the first discussant for PFAS, and that's Dr. Stern. So if you would please go ahead and give us your summary comments on PFAS.
Sure, I'll go ahead. So just a bit of background, PFAS are present in industrial and household products, including firefighting foams, stain or water-resistant coatings for cookware, fabrics, leather, food packaging, and paper products. These type of chemicals are extensively used as processing aids in the manufacture of fluoropolymers to produce items such as non-stick surfaces and the other compounds that the other products that I just mentioned. So they are present in many things that were exposed on a daily basis. In the US, production was phased in early 2000, but they're still made elsewhere in the world. And with import of products, that means that we continue to be exposed. There's also production still of chemicals that can be transformed or degraded to release PFOS. One of them is ethyl perfluorooctane sulfonamidoacetic acid, which I will refer to as ETFOSA. Which is a biological metabolite of the raw material ETFOSE, which is used in the manufacture of packaging and paper products. This compound is a precursor that eventually leads to PFAS, which PFAS itself is highly stable, so it's a persistent product that is not further metabolized. There's also another compound called PFOSA, which is used to repel grease and water in food packing, along with other applications, and this one can break down to PFOS. So the routes of exposure are several. It can be inhaled, it can enter through mouth, it can enter through dermal absorption. It is readily absorbed into other organisms, so it's present in fish and other foods, as well as drinking water. Studies in different places, including LA County, have found that it's detectable in human specimens. The half-life in humans has been estimated between 4 to 5 years, and in water, it can be more than 92 years. In terms of the biological effects, I will not go into detail. I will let my colleague, Dr. Shang, summarize that evidence, but I just want to highlight a few things. One is that PFOS are members of the PFAS family, which are environmental endocrine disruptive chemicals, which means that they can alter normal patterns of tissue organization and interfere with stromal epithelial interactions. There's a whole host of potential biological effects that can be induced by these type of chemicals. It seems that for PFOS, the main target might be the liver, based on animal studies, where it can alter metabolic processes, including reduction or alterations of cholesterol levels. There are other studies that have shown that it can be linked to mammary carcinogenesis. So I will focus mostly on the epidemiological evidence. So there were a total of 19 studies that were provided to us by OEHHA. So thank you for those materials. And these included studies that cover about 9 different cancer types. And I will give you more details. Now, 2 of the studies actually reported on patients that had been included in a prior study. So there were actually 17 unique studies that we can comment on. The studies including both case control studies that were nested in prospective cohorts, as well as regular case control studies and a few cross-sectional studies. There were 3 cohorts that contributed data. One is an occupational cohort in Alabama that contributed data for several cancers. Then there's also the Danish birth cohort and the Child Health and Developmental Studies pregnancy cohort that contribute data for breast. So overall, the big picture for the epidemiological evidence is that 2 of the 17 studies show evidence of positive associations between PFOS and breast cancer, and I'll give you a bit more detail about that. There were 5 studies of the 17 that show some suggestive evidence with findings that were either only significant among some subgroups or they were not significant for PFOS, but they were significant for the precursors. There were 5 studies that show evidence of positive associations, but they were not significant. And 4 studies that show no evidence of association, and 1 study that actually showed an inverse association that was significant. All studies except 1 use blood measurements of PFOS or the precursors, and the Alabama occupational cohort used job descriptions. So I will focus mostly on the breast cancer studies for which there were some significant findings. There were 7 studies that look at breast cancer. 1 is a nested case control study that was done in France, and it was done in a cohort of women involved in education called the E3N cohort of about 100,000 women. And when they look at all the cases, include all the tumor types combined, they did see some evidence of significant associations that were only significant for 1 of the quartiles, but not those response trend. However, when they divided the women based on the estrogen receptor status, they found that among women that had estrogen receptive positive tumors, there were significant associations and they saw a significant trend. Similar for women that had positive progesterone receptor status. The numbers for estrogen receptor negative and progesterone receptor negative tumors were very small, so the confidence intervals were very wide. So I think those data were very unreliable. The other study was a study done in Greenland among Inuit participants. And one of them, just the motivations to the study is because of the high exposure based on high intake of marine mammals, which are may have high concentrations of PFOS. So in this study, they did see dose response with significant associations with the highest total with an odds ratio of 5. Most of the women in this study were postmenopausal. So those were the 2 positive studies. Then there were 4 additional studies on breast, 1 case control and 3 nested case control studies that did not really find strong evidence for an association with PFOS itself, but they did find when they did subgroups. For example, 1 case control study done in Taiwan found positive associations when taking into account age at diagnosis, but not really when looking at all women combined. Then there was another study that was done as a nested case control study within a pregnancy cohort. And here what they did is they look at the daughters of the women that were in the cohort. So these are fairly young diagnoses. And what they did here is they did not really find associations with PFOS. They didn't report data for PFOS alone. They look at it in combination with interactions with cholesterol. They didn't see any evidence of association with PFOS regardless of cholesterol levels, but they did see a positive association with the precursor ETFO-SAA when cholesterol was high, but not when cholesterol was low. Another study that was done also shows similar pattern. This was an nested case control study in the Danish birth cohort. They didn't see much evidence of association with PFOS, but they did see association with PFOS-A, which is a precursor. And then finally, there was another study that follow up on that study where they look at some interactions with metabolism enzymes, and they found some evidence of interaction for PFOS-A and for PFOS with 2 metabolic enzymes. But so not really supporting association with the compound itself, but supporting that there could be some susceptibility in the population. Finally, the Alabama occupational cohort did look at breast cancer, and they did find elevated standardized mortality ratios for breast cancer, but there were only two individuals that were diagnosed in the cohort. So very, very, very wide confidence interval for that. So in conclusion, for breast, there's some suggestive evidence that there might be associations, but only among estrogen receptor or progesterone receptor positive cases, and some positive associations, mostly with the precursors, but not with PFOS itself. There were some additional studies, 2 additional studies in bladder. One was a case cohort study, the other one was a cohort study with the Alabama cohort. No real evidence of association there. For prostate cancer, the Denmark cohort, they did a case cohort study, and they did find elevated odds ratios, but no real evidence of those response. And then finally, there were a study in pancreas cancer that didn't find any association. Liver cancer, same. There were only 2 studies. One was from the Denmark cohort, one from the Alabama. The Alabama cohort, again, they found some evidence of elevated mortality ratios, but there were only 2 deaths reported of liver cancer in the cohort, so very, very low power to detect a significant increase. There were multiple other cancers that were examined in the Alabama cohort, like esophagus and melanoma, both of which they found elevated mortality ratios, but again, very wide confidence intervals because of very small numbers. As I mentioned, there was one study done in a cross-section. It was a cross-sectional study that reported inverse associations with colorectal cancer, and they couldn't quite explain this. And there was another cross-sectional study done in Greece that did not find evidence of association. So pretty much the available evidence seems to support some potential effect for breast cancer, potentially estrogen receptor and progesterone receptor tumors, and no real evidence for other cancers. So I won't go into the details of the animal studies. I will let Dr. Shang do that. However, just briefly, there's some evidence of association with mostly adenomas, but not carcinomas. No studies that support an association with breast. Only 4 studies were reported. One actually considered PFOS as a promoter and not as an initiation agent. In terms of genotoxicity, of these 18 studies that I read in the documents, only 11 were positive. There's some evidence that it may induce epigenetic alterations, some evidence of oxidative stress. So there's some supportive evidence that it may have carcinogen activity. The intriguing part is that there are 10 studies that support 10 studies that investigated whether it could modulate receptor-mediated effects, and 7 of those studies were positive, and they show data that is consistent with a mechanism through the estrogen and the androgen pathways, which is compatible and consistent with the findings from the epidemiological literature. There are also 3 studies that support effects on proliferation and anti-apoptotic activity, some studies supportive of chronic inflammation, and 2 studies that support it may have immortalization effects. So overall, my reading of the evidence is that the mechanistic effects are consistent with alterations of estrogen or androgen pathways with some carcinogenic processes. The epidemiological evidence has two studies that support a possible association with breast cancer, particularly estrogen positive, estrogen receptor positive cancer and progesterone positive cancers, and very limited and weaker evidence for prostate. So based on all these, I'm kind of in between a medium and a high. I think based on the evidence, it feels like more of a medium to me, but because there's still potential exposure through imported goods, and because of the potential role it may have on disrupting estrogen and androgen pathways and the evidence from breast cancer, I think I'm gonna start with a high, and I'm gonna welcome comments from the panel before I make my final vote. And I'm gonna stop
Thank you
here.
very much. Okay, thanks. Thanks a lot. Dr. Jung, you're next discussant.
Yes.
It's like you're on mute.
Hi, can you hear me? Okay,
Yeah.
good. Yes, I want to thank Dr. Stan and give us a pretty good overview on the IP study and the general exposure as well. And I think one thing I want to just put here, because we're actually reviewing not just one chemical, not just the PFAS, but also including PFAS, the salts of the PFAS, for example, P4A and other types. So this is one, and also including some precursor. Some chemicals can, after being metabolized to the PFAS. And also PFAS is a major chemical in this PFAS. This is much bigger, including maybe thousands of different PFAS family. But I think PFAS is actually major one of the major P4 and the P4S. It's two major ones in the PFAS family. So I just want to put this ahead. And also I like to thank OEHHA staff to actually put this review together. And one other thing is about exposure on the PFAS is from, I believe it's from an enhanced study. They have see widespread exposure, and also the PFAS has been detected in 98% of blood samples screened. So that's the exposure right there. And from what Dr. Stan already reviewed in human studies, to me, looks like the breast cancer incidence related with PFAS exposure seems more stand up than other type of cancers. So my review is going to be majorly focus on animal carcinogenicity data and findings and the potential mechanism. So this is a two-part. For the animal cancer incidence studies, so they had long-term, that's including 2 years exposure, or I would say medium or shorter term is only like about 1 year, 52. So, and I think I mostly agreed with what OEHHA staff documents have been put together. So to me, the incidence of liver adenoma in rats has been, tested and reported in quite a few different studies, and the p-value is, about 0.01 or the 0.05. So the liver adenoma in comparison with other type of cancer, such as also we see the increase. By the way, I just want to put it here. My power in the house is shaking. My light is turning on and off. Okay, just in case if I'm off. I'm just trying to, I have no idea why. I think it's the weather here. So my light is on and off. Let me back to the animal data. So for the thyroid follicular cell adenoma, also they did see some increase the incidence on that, but mostly at the highest dose tested. That's a second highest dose tested, but not at the highest dose somehow. So overall for the thyroid adenoma, didn't see the, it's not statistically significant. But for the short-term study, the 1-year study, and they did see the thyroid follicular cell adenoma in mild rats, but that's only what they see. They had only at the highest dose, 20 ppm PFOS. So anyway, overall, I see the animal study still kind of limited, but the data showing clearly the liver adenoma seems is pretty real. And another that's a study on the tumor promotion study in the rainbow trout. Also, whether they have using the using the 10 ppm aflatoxin B1 as an initiator, and then treat the trout for 6 months at the for the 100 ppm. It's pretty high PFOS, but what they did see is the increase the liver cancer in the trout. So, and that's very significant. So looks like what they're showing is PFOS in that system is acting as a tumor promoter. But if there is no initiator, they didn't see increase the liver cancer. So that's what I see. I sort of see the animal data looks like. So the next, I would like to focus on the potential mechanism. So here, OEHHA has used the key characteristics approach, which was promoted by Smith 2016 paper. So far it's about 4 or 5 years. This approach has been applied by IRAC and also some NTP and EPA studies as well. So I'm just trying to here to look at what so far the PFAS KC reviewed by OEHHA is it looks like had 8 of the 10 key characteristics of carcinogens seems reported some kind of studies all positive or potentially positive. So that's 10 of them, except the KC1 and the 3. That's so I would go into a bit detail, but I'm just telling you how I'm trying to analyze the data. So first, see that the OEHHA data, but also for the using the KC approach, the environmental working group has also reviewed PFAS, including PFOS and the other PFAS chemicals and look at each cases from 1 to 10. So basically trying to compare, not just taking the OEHA documents, but also looking at the environmental working groups report. And then I have also analyzed particularly on the 2 immunotoxicity cases, that's including KC6, KC7, that's chronic inflammation and immunosuppression. So, and using the knowledge we have. So this is basically an approach I'm trying to put ahead. How do I analyze this potential mechanism data? So in general, there are, I think, 4 cases has a little discrepancy between different reports or different reviews or my personal opinions. First is the KC2 genotoxicity. Looks like there are some studies reported positive findings in micronuclei induction and the DNA strand breaks by comet, and also some mutations. And so that's what we see. But to me, the data is still pretty weak. And the environmental working group actually concluded this genotoxicity is actually no genotoxicity. In my opinion, would be either weak or weak genotoxicants. So that's for the KC2. For the KC4 epigenetics, there is some strongly suggestive studies. So this KC4 actually, I think both OEHA and the environmental working group had put in as suggestive positive, and based on kind of a global hypomethylation using line 1 and some specific gene methylations. But I still think I would still think even though the epigenetics has been reviewed all in human studies, animal studies, and in vitro study, I still think we need more data to really describe details of how PFAS can generate the epigenetic effect. So KC9 immortalization, this is only looks like a very limited studies, and there's 2 reviewed by OEHA, but the environmental working group actually thought it's not sufficient. So I'm just trying to put this discrepancy mechanism first. And the KC10 cell growth and the death is, most of the studies looks very positive, but the only problem is almost in vitro studies. So there's no in vivo studies to support. So now, what we have now is a major or strong cases. So that's the cases 5 to 8. And the 2 of the cases actually is basically either no data at all or very limited data. That's the KC1 and 3, so we don't have to talk about. So the oxidative stress, that's a KC5, and looks like very strong evidence in multiple studies, and all crossing all 3 systems in human study, animal studies, and in vitro, has been seen the reactive oxidative species increase, and lipid peroxidation increase the 8-hydroxyguanosine, and also glutathione and glutathione peroxidase, the glutathione depletion. So oxidative stress, I think that's also could be a way for us to see some weak genotoxicity could also caused by the oxidative stress. But to me, the PFAS itself, it may not be a very strong genotoxic. It could, after we have more data, I think through epigenetic mechanism could be stronger than the genotoxic mechanism. So that's the one point I want to put in there. Then second is I also want to make sure here I have independently reviewed the NTP 2016, the report on immunotoxicity, and which include inflammation and immunosuppression of the P4 and the PFOS. So and also recently we have systematically reviewed this 2 immunotoxicity involved cases in benzene, benzene-induced cancers, and also we are currently review the PFAS, including PFAS. So and I just look at a little bit more details about where PFAS and the PFAS salts and other related chemicals can cause immunotoxicity. So to me, actually, I think the major and also pretty strong mechanism is through the immunotoxic mechanism. So what we are seeing is increased the cytokine productions or cytokine activities, especially in the interleukin-6, and also the pro-inflammatory cytokine, the TNF-alpha. I mean, this is a 2 major one because that's already reported by multiple different studies. But of course, there are many other cytokines, increased cytokine production like interleukin-1 alpha, interleukin-1 beta, and interleukin 8 or 10, etc. So that's, to me, it's enough to see PFAS related or induce the chronic inflammation. For the immunosuppression, KC7, what actually most of the data showing is a decrease the natural killer cells in multiple studies and also across most 3 in vitro and in vivo as well. So here, not only natural killer cells decreased, but also other type of white blood cells, particularly CD4, CD8 T cells, and interferon gamma, etc. And so that's why I actually think PFAS induced immunotoxicity could be a major one as well. The last, I think, is also the most important is the KC8, is a receptor-mediated effect. If you remember what Dr. Sen also summarized from the human study, for the breast cancer and, potential estrogen kind of related cancers. So from this specific key characteristics, what have reported is a Bpa alpha, Bpa gamma, and ER, AR, and other type of receptors. All see they are related with PFAS exposure, and particularly again this receptor involved effect has been seen again in the human exposed studies and animal, in vivo, and in vitro studies. But of course, there are still a couple of negative studies, but I see the most evidence is still in the positive studies. So here really make me really thinking is PFAS, if PFAS may act as a estrogen disruptor chemicals. So I think maybe, Michelle Lamura could, tell us even more since that's her field. But again, I don't remember if Dr. Stan mentioned this, but I think this is SLP studies involved in the estrogen metabolized genes. They also see some of the, polymorphous association. So that's all kind of supportive. So overall, in summary, I think based on the data reviewed so far, the breast cancer incidence associated with the exposure in humans and the liver adenoma incidence in rats, and I would say strong evidence in the key characteristics 5 to 8. That's including oxidative stress, immunotoxicity, and the receptor-mediated effect in Bpa, etc. I would recommend the PFAS and its related chemicals to be high prioritized. Thank you.
Okay, thank you very much. Let's see if there are preliminary comments from the rest of the committee. Merrill, I see your hand.
Hi, yeah, so to address what Professor Zhang just said, my take on the estrogen receptor data is that it's kind of mixed. It's difficult to understand exactly what's going on without reading the papers in depth to understand what were the differences, because it wasn't always the same reaction. There were two null studies saying that ER activity was not modulated by PFAS. One was one supposedly looked at several human cell lines, and one was a yeast 2 hybrid assay. But then there was a couple that did. Obviously, selective estrogen receptor modulation is real because we talk about that with the chemotherapy tamoxifen. And so, there could be some contextual, biologically plausible explanations for those differences. And I would really kind of need to look at it more carefully, but certainly in combination with all of the breast cancer studies, it kind of raises my eyebrows, so to speak, in terms of being interested in looking at the full data more in depth across the different study types. And Professor Stern, I actually had a question for you, or maybe a couple. I noticed when I looked through the epi that it was the birth cohorts in particular where they did not find PFAS significant, but in both of those birth cohorts, they instead named the upstream precursor. And one, it was PFOS-A, and the other one, it was ET-FOSA. And I was just wondering if that was your impression, and kind of what was your take? Like, do you think there's anything significant about that? I thought it was interesting that those were the only two birth studies, and that the PFAS was not wasn't positively associated, not insignificant. And the other question I had for you was the Taiwan hospital study, because I know there was a lot of subgroup analyses, and the Taiwan one was saying PFAS was positively associated with breast cancer in young women 50 years and younger. And I was just wondering, was that the nature of their study design, or did they have older women as well and just kind of arbitrarily use that division rather than, for example, menopause status?
Yeah, to answer that last question first, and then I'll go to the birth cohort study. So I don't know, I don't recall the motivation for why they stratify by age and not just menopausal status. I noticed that 46% of the participants were menopausal, postmenopausal women. So they had half and half of the women were pre and postmenopausal, but you're correct. When they look at all the women combined, they don't see evidence of association with PFOS, but when they stratify based on age, they notice that there was a positive association among the younger women, those diagnosed before age 50. And then they did an additional sub-analysis combining the age with the estrogen receptor status, and they found that among women that had estrogen receptor positive tumors and were younger than 50, then there was a positive association that was not observed among the other comparison groups. But the rationale for why they stratify by young diagnosis, I don't recall. They don't remember if they mentioned something. I do remember that they mentioned some concern about increasing rates of breast cancer in Taiwan. So maybe they are seeing higher rates with potentially some increasing numbers of younger diagnoses, and maybe that's why they wanted to do that. I would have to pull the paper and look at it again. And then your second comment was for the birth cohort, the Danish birth cohort, and yes, you're correct. They did not see an association with PFOS, but they saw an association with PFOS-A, which is considered to be a precursor, with an association with the highest quintile. Let me see what else. In this particular cohort, most of the women that were studied were premenopausal. Was that the study you referred to?
Yeah, it was that one in CHDS. I was just curious if, if anybody in general thought that there might be a reason why the precursor, I just thought it was strange that the only studies that had precursors that were significant were the two birth cohorts.
Yeah, so there was one study that, oh, sorry, go ahead. One of the studies offer an explanation, but go ahead, follow up with your thought, and then I'll answer that.
No, it's fine. I just, it could be due to chance. It's not a large N of a cluster. I just thought, well, is this something we need to consider?
One of the studies, because I think there are several studies that were done with, so they're independent studies, not all done with the same cohort. There are a few independent studies that have the same pattern, no association with PFOS, but association with the precursors. So one of the studies, which was the pregnancy cohort done in California, which look at the daughters of the women involved in the cohort, they offer a potential explanation. In none of the studies I saw that they could understand why they see the association with the precursor, but not with the actual compound. But one explanation that they offer is that maybe there's faster metabolism of the PFOS, and that's why it's harder to detect it. But maybe the precursor that has a different metabolism, and maybe that's why it's easier to detect it, and that's why we tend to see the positive association. But I was curious as to the fact that there are several studies that have that finding of not having an association with PFOS, but having an association with the precursor.
And Prof. Zhang, just to clarify, all of the experimental work was done with PFOS, not the precursors, correct? All the cases, it seemed like it was all PFOS when I looked. Yeah.
I think so. I'm going to let Dr. Shah confirm. My understanding is, yeah, they all look at least the ones that we were provided, they all were based on PFOS and not the precursors.
Yeah.
One thing I want to mention that was not part of the materials that we were given, but this is something that I found that was interesting, is that there's some growing literature showing that PFOS may, or PFAS in general, perhaps PFOS, they may have a relationship with non-alcoholic fatty liver disease, which, as we know, is a precursor of liver cancer. So this is something to consider that might be interesting to look at in more detail if we move forward with evaluation of this carcinogen later on. because of the rising trends of liver cancer among Hispanics here in California and the relationship with non-alcoholic fatty liver disease.
Okay, let's take a note of that and see whether any other members of the committee have preliminary comments. Anything to add? Not seeing any hands raised at this point. I believe we have one person who's asked to make a public comment. So, Clara, if you could allow that, please.
Absolutely. It looks like we have Steve Risotto with his hand raised. And Steve, I've unmuted you, so go ahead.
All right. Thank you very much. Can you hear me okay?
We can.
Okay, awesome. Good afternoon, Dr. Loomis and committee members. I'm Steve Risotto, and I am a senior director at the American Chemistry Council. I'm here to comment on the committee's consideration of perfluorooctane sulfonate, or PFOS. ACC has submitted written comments, and I'd like to briefly summarize those comments for you now. For starters, PFOS does not appear to meet the screening criteria for consideration by the committee laid out by OEHHA staff this morning. Referring to the information in Table 2 of page 6 of the prioritization document prepared by the staff, we note that there's only one animal cancer bioassay available for PFOS, and the results of that study do not report evidence for tumors at multiple sites associated with PFOS exposure. In addition, OEHHA staff have provided minimal evidence of tumor promotion for PFOS. And finally, PFOS is not structurally similar to any chemicals that have been identified as carcinogens under Prop 65. In response to Dr. Sun's earlier remarks, perfluorooctanoic acid, or PFOA, has not been identified as a carcinogen under Prop 65, and a look at the structure of tetrafluoroethylene and the fact that it is readily metabolized reveals little similarity to PFOS. As noted in the staff summary, the epidemiological evidence for PFOS is generally negative. However, recent case control studies have suggested an association with hormone receptor status among women with breast cancer in France and Taiwan. In both cases, the association with estrogen receptor positive tumors, the most commonly diagnosed tumor type, while the association with overall breast cancer incidence was less clear. Both studies were based on a single blood sample, which in the case of the study among French women may have been taken several years before diagnosis, and the concentrations reported vary significantly between the two studies. In addition, while the increase was observed among older women in the French study, there was no similarly observed increase among women over 50 years old in the study in Taiwan. Regarding the single cancer bioassay in rats, the reported increase in liver adenomas and carcinomas was accompanied by an increase in the incidence of the liver cell necrosis and hypertrophy, similar to that reported in short-term studies with PFOS. As a result, the authors concluded that the liver effects were consistent with activation by nuclear receptor PPAR alpha and CAR-PXR, and that the available data do not provide support for cancer risk from exposure to PFOS. The other tumor types reported in the bioassay lacked dose response and had a comparable incidence across dose groups, including among the control animals. Based on negative results of a large series of in vitro and in vivo short-term tests of genes, chromosomes, or DNA repair, PFOS and its salts are not considered to be genotoxic. However, the prioritization document provides information on studies examining the effects of PFOS on 6 other characteristics that have been associated with carcinogenic potential. While the application of these characteristics may be useful for identifying and organizing relevant data, it is critical that they be combined with an understanding of the plausibility and causal linkages of the key events and biological responses involved in carcinogenesis. Without a critical evaluation and integration of the mechanistic evidence, application of the identified characteristics is of limited value in supporting a scientifically defensible conclusion of carcinogenic potential. Given the limited animal and human evidence and the uncertainty about the significance of mechanistic information, ACC recommends that PFOS remain a medium priority for consideration as a Proposition 65 carcinogen. Thank you, and I'd be happy to answer any questions.
Thank you for that comment and for staying within your time limit. Let's go back to the committee now and see if there's any further discussion on PFOS. I see several hands. Let's go to Dr. McDonald, who hasn't spoken yet.
Yeah, I just wanted to make a point that, you know, the nature of PFOS is in the body is very, very long lived. And so a single measurement can serve as an integrated measure of years of exposure. So I just wanted to add that point.
Okay, thanks. I saw Dr. Zhang had her hand up again. Go ahead, please.
Yes, I support what Tom McDonald just said. And not only PFAS has a long lifetime, and also it's not only persistent in the body, it's also persistent in the environment as well. One other comment I may want to ask OEHHA staff. I heard from Dr. Song is a PFOA has already been listed as a high priority. Is that a case? Because P4A and P4S, there's two major compounds in the PFAS. So I just want to make sure, is that true? P4A has already been listed as a high priority, and if yes, when? This is my question.
You're on mute.
Sorry. Yeah, to answer your question, Dr. John, PFOA is currently a high priority chemical. And we can look up the year that it was ranked by your committee and get back to you. But currently it's a high.
Okay, other comments, Dr. Lamerle?
Yeah, I just want to briefly point out that PPAR alpha is bound and modulated in its activity when it's the human form as well as the mouse form by PFOS that's been published. And so there has been some, I think earlier on in the literature, there was some questioning on whether or not the peroxisome proliferation was relevant to humans by the PFOA and PFOS. And I think that with PFOA, which is very chemically similar, they have shown that you get a very similar profile even when you use a humanized PPAR alpha in a mouse, and it's been shown that PFOS can bind the humanized one. So to take note of that. And also, although there was a number of subgroup analyses that kind of dampened my enthusiasm about the breast cancer in humans somewhat, I would like to point out that people in the breast cancer community really feel that each of the breast cancer subtypes are really distinct diseases. So to look at ER positive and PR positive breast cancer as a subgroup, I think it is like saying that in contrast, we should just combine all hematopoietic cancers. And we know that it's not appropriate either. And so I do feel that that wasn't kind of overly cherry picking in that context.
Okay, thanks. I'm going to add a comment myself. You know, I was also struck by the epidemiologic data, and while acknowledging that there are a number of puzzling findings and that some of the results come from subgroup analyses, you know, having looked at a lot of putative endocrine disruptors with an eye to these endocrine-related tumors, we don't often see this kind of indication of an association. So although I still wouldn't call this sufficient evidence of carcinogenicity, I do think it is kind of compelling. Please go ahead, Mariana.
Oh, sorry, I didn't hear you. I just want to add one comment in response to the comment from the public comments that we heard regarding the epidemiological study from the cohort study, which is, in my view, is I think the strongest evidence that we have from all the epidemiological studies that we reviewed. This is the France study, which is a nested case control study in a cohort. This is a large cohort of 100,000 women. And in the public comment, we heard concern about the fact that the measurement was done years before the cancer developed. But I want to highlight that from my perspective, that's a strength of this data, because typically we want to measure the exposure before the disease developed so that we can eliminate any potential concern about reverse causation bias. So I think that adds the strength to the study that the samples were obtained before the women went on to develop breast cancer, which we know may take many years to develop. So I just wanted to add that perspective to the study, and I agree with the comment made by Dr. Lameriel that I think looking at in epidemiological studies of breast cancer, looking at associations stratifying by estrogen and progesterone receptor is pretty much expected. We always do that because we do consider that the risk factors can be different for these two subtypes of diseases.
Thanks. That's a very good comment about the exposure assessment. I had the same observation, and I agree with it. Let's see. Dr. Zhang, another quick comment?
Sorry, yeah, a quick comment. Also, I think the breast cancer studies, Dr. Stan, remind us, but also I see the generally for the stratified different exposure, different category, and they see kind of a P trend, positive P trend, in this human studies. It's difficult, but I think here for the breast cancer, they couple of the studies they did show the significant P trend. I think that's also convinced and make me convinced that the cancer incidence related with exposure is right there. Just want to make that point.
Thank you. Let's see if there's any more discussion from the committee before we go around and take a vote. I'm not seeing any other hands. So unless anybody wants to jump in really quickly, let's go ahead in the order in which I see you on the screen. Dr. Bush?
I'm going to say hi.
Dr. Eastman?
I'd probably go with medium to high, so put me at medium.
Medium, you say? Dr. Lameriel?
Hi.
Dr. Schultz? Can't hear you, Dr. Reynolds.
Oh, hi, I didn't hear you.
Okay. Dr. Stern?
Hi.
Hi. Dr. Zhang?
Hi.
Hi. Dr. Crespi?
Voting for high.
Dr. Landolf?
Medium. Medium.
Dr. Mack? Dr. Mack?
Hi.
Hi. Okay, I heard that. And Dr. McDonald?
Medium.
Medium. And so I think we go to high. Let's see, we've been going an hour on that compound, and I'm still without power here, so I'm going to have to change back to my phone. So I'll suggest another 5-minute break. So let's reconvene at about 7 minutes after 3. back. I can't tell whether anybody else is there.
Yes, we can hear you.
Okay, good.
6 of us have returned. 7 now.
Okay. Okay. Somebody could let me know when everyone's there, then we'll get started again.
We're at 8 now.
8 are visible plus you.
So that makes 9, yeah.
That makes 9. Okay, so let's go ahead with the last substance then. That is trifluralin. And Dr. Bush is the first discussant.
All right, thank you. Good afternoon, colleagues. I'd say last but not least, right? It's been a interesting afternoon. I do want to thank OEHHA staff for providing the brief and other reviewed materials. And thank you to the public commentary from the Gowan Company. I have read your 12-page comment document and have factored that into my wing of the evidence of trifluralin. So I'll briefly discuss the major contributing factors to my deliberation of the toxicological and the mechanistic data, and I'll leave the details of the epi data to be explained by Dr. Loomis. But in summary, I found the collective epi data to be limited. So some quick background. As the brief indicated, usage in California is about 347,000 pounds, as reported in 2017 by DPR. Nationwide, the available data is around 14 million pounds, but the data that I could see was last reported around 2001. So presumably it's more than that at this point. So that makes trifluralin one of the most widely used herbicides in the country. And now trifluralin, like other members of the dinitroanilines, is an anti-mitotic compound that affects presumably microtubule depolymerization, thus interfering with mitosis, particularly in the meristomatic regions of plant roots, since it's generally applied to the soil. We know that as a consequence, the mitotic spindle doesn't form. That causes misalignment, chromosome segregation artifacts, and potentially some non-disjunctions. As a class, the dinitroanilines have different affinities to tubulin proteins, of course, the basic component of cellular microtubule networks for those in the audience. Dinitroanilines, like trifluralin, generally have higher affinity for plant tubulin, but I'm going to remind people that tubulins are one of the most conserved proteins across eukaryotic cells, and that includes animal cells and human cells. Considering the putative chemical degradation of trifluralin, we can see that it promotes some dealkylation of the amino group. This herbicide tends to receive 2 electrons, so suggestion of some electrophilicity. We know that of course increases the toxicity, and this facilitates this compound to bind with the polar groups, particularly of cellular membranes. So there's some alternative mechanisms suggested that trifluralin may interfere with permeability, of plasma and mitochondrial membranes. This can change the quantity of particularly calcium flow within the cytoplasm, and it's been noted in the literature that trifluralin action can alter calcium-dependent biochemical and physiological processes. Furthermore, biodegradation derivatives like anilines and halogens from this group are known to induce metahemoglobin formation and thus also be toxic to kidneys and liver, either in vitro or in vivo. And this is now that possibly contributes to the fact that trifluralin is known to be acutely toxic in fish. So moving on into the animal carcinogenicity bioassays, basically the brief provided us with a total of 7 studies, 4 in rat and 3 in mice. 2 of the initial long-term studies from the late 70s, I'm not going to use in my calculus because of potential contamination of the trifluoralin with carcinogenic NDPA, which is presumably an off reaction that occurs in this class of chemicals during synthesis. So that effectively gives us 5 animal studies. I'll briefly go through them. There was a 1966 study evaluated by the US EPA in 1986 on Sprague-Dawley rats. There was effectively no treatment-related tumor findings, but the highest concentration in that feed study was around 2,000 ppm. That was followed up in 1980 by studies on 344 rats, so that was a 2-year study. That showed some statistically significant high dose response at 6,500 ppm within the feed. That led to some increases in urinary tract and combined thyroid tumors in males and urinary bladder tumors in females. Now, some of this information is disputed by the public comments, and it was speculated in the US EPA report that those tumors that we were seeing are a result of non-target organ effect, but I didn't see any data to directly support that conclusion. Moving on. In 87, there was then a 28-month study in Y-star rats that identified some benign brain and liver tumors, but this was suggested to be related to age and not due to treatment. And then there are 2 mice studies. Another one in 1980 that showed effectively no treatment-related findings in either sex, and then different strain of mice in 87 with NMRI mice. There were no treatment-related findings in female mice, but some liver and lung tumors by pairwise comparisons with the control, but no statistically significant trend in dose response in the males. So, taking that information, I would say that the data is limited for the animal studies and suggests to me, a low to medium priority. But delving into the key characteristics of carcinogens, it gets interesting. The data is mixed again, but unlike the public comments from Gowan, I largely see a positive association with genotoxic, genomic instability that includes some chromosomal abnormalities, potential DNA damage in human and other mammalian cells. That would fit with the mechanism of interfering with the mitotic spindle. In general, mutagenicity is negative. Particularly in bacteria, wouldn't expect that since we don't really have, prokaryotes don't really have conventional tubulin, thus this wouldn't be a target for them. There's some recent published studies demonstrating positive correlations with altered DNA repair and induction of reactive oxygen species, again in both human and rodent cell models. And that suggests then mechanistically that there is something going on, at least in my reading of the data. So mechanistically, we know that there's some modulation of various hormone receptors, both in vivo and in over 10% of the 883 ToxCast assays. That included responses from estrogen receptor, pregnetin X receptor, thyroid hormone, and that's particularly disconcerting towards the dysfunction in key pro-growth signaling cascades, and that may validate some of the carcinogenic effects we're seeing in some of the animal studies. OEHHA staff identified trifluoralin positive in 4 out of the 10 key characteristics of carcinogens from table 2 in the brief that they gave us. I'd argue that the degradation pathways kind of bring in a potential 5th characteristic of electrophilic nature. So when I take this information and consider that along with the structural similarities to other dinitroanilines that have been listed as carcinogenic under Prop 65, in particular oryzalin. If you look at the structure of oryzalin and trifluoralin, basically overlap them. Taking those into consideration, the evidence becomes a lot more compelling, even without considering the limited epi data. So, considering the available data in the context of the key characteristics of carcinogens, and I'm going to get on a soapbox just a little bit, those key characteristics of carcinogens as unified in Smith and all in 2016 and adopted by IARC, there's 2 concepts that come to mind, and I'll quote from the paper directly. First, the description by Hanahan and Weinberg of hallmarks of cancer is predicated not on morphology or the impact of carcinogens, but on changes in gene expression and cell signaling. Secondly, in 2012, participants at the 2 workshops, and some of the committee may have been there, participants at the 2 workshops convened by IARC in France extensively debated the mechanisms by which agents identified as human carcinogens produce cancer, that is the group 1 carcinogens. They concluded that these carcinogens frequently exhibit greater than 1 of the 10 key characteristics. To me, trifluoralin is exhibiting at least 5 of these characteristics. Now, integrating the streams of evidence using the IARC model, I see trifluoralin as probably carcinogenic to humans, and thus I would rank it as a high priority. Thank you.
Okay, thank you for that summary. That's very helpful. I don't have very much to add. I'm the second discussant. I don't have very much to add to my colleague's summary of the key characteristics, except to say I was at those meetings, and I think that concept of the key characteristics of carcinogens has been really useful for IARC, and now I'm happy to see it applied elsewhere. And I also noted those characteristics in my review, but I'm going to focus on the epidemiologic data, which is spotty. Essentially, we have information on a lot of different cancers from the Agricultural Health Study, as I count them, 5 different case control studies of different adult cancers in the U.S. Midwest, case control study by Dr. Reynolds of childhood cancer in California, and another study of ovarian cancer in Italy. So we have data on about a dozen different cancers, but there are only a few for which data has been reported in more than 1 study. So I'll highlight those. Non-Hodgkin lymphoma was increased in men who ever used trifluoralin in 2 case control studies in the U.S. Midwest, but not associated with increasing lifetime exposure to trifluoralin in the Agricultural Health Study. All types of leukemia combined, which we've already discussed, not really the way we like to do things anymore, but that's the way it was reported in many studies, not associated with any measure of exposure to trifluoralin. But in the childhood cancer study in California, acute lymphocytic leukemia was elevated, but not statistically significant. in high use areas. Brain cancer was associated with ever use of trifluralin in a study of adult male farmers in the U.S. Midwest. But the authors noted that that association was primarily in subjects whose information was obtained in interviews with proxies rather than with the subject himself. And brain cancer wasn't associated with trifluralin in the childhood cancer study. So there's data for a number of other cancers, cancer of the stomach, esophagus, and colon, rectum, and so on, but those findings were reported in one study each, most of those in the cohort analysis of the agricultural health study. And those findings are basically unremarkable. So we have, in essence, rather sparse data that doesn't demonstrate, as I see it, any consistent association with cancer at any site and exposure to trifluralin. So exposure response data are available only from the agricultural health study and the childhood cancer study. And the only significant trend was observed for colon cancer in the agricultural health study, but that wasn't, that cancer wasn't studied in any other case control study or cohort study. So the data are, I would say, on the border between inadequate and limited, and consideration of the animal and mechanistic data. I also was on the point somewhere between medium and low priority. After hearing Dr. Bush's summary, I think I would move up to medium. Now, let's see whether there are any comments from other members of the committee. If someone could again help me and identify anyone who wants to speak.
Okay, Dr. Lamero?
Yeah, I have a
Go ahead,
question.
please.
Thank you. I have a question for Dr. Zhang. Since you do work with hematopoietic origin cancers, I was wondering if you could comment. I don't love the way that they were aggregated, but we just heard from Dr. Lomas that it sounded like there might be something going on there. Do you think the mechanisms that Dr. Bush told us about would support that?
See, I think hematopoietic cancers are a little bit complicated because that's all, many come from a stem cells, hematopoietic stem cell, but it also depends on the head in, mechanistically head in where it's in early stem cell or a little bit later or in the progenitor stem cells. So that's a little bit difficult to say because I think using the ICD code, they still could classify a different type of cancer. But I think mechanistically, for me, I would really think, if it's had in the earlier or the stem cells, I would say that could, they could go from top of the stem. It can go either lymphoma, had in a lymphoid stem cell or myeloid stem cell. So that still could be, generate either lymphomas or leukemias. So that's why I think previously NCI would, kind of together to say what's called the myelo, so put them all together, right? So it really depends. I would say if we have limited studies or limited cases, I think it's okay to put them all together. Or if we understand the mechanism, the head is at the earlier progenitor or the later progenitor or stem, then you can separate them. I don't know, Michelle, did I answer your question?
Yeah, thank you.
Yeah, that's the point.
Are there any other comments from the committee? Again, somebody please help me.
This is
David.
Dave.
Go ahead.
Just want to mention, these compounds do induce aneuploidy, interferon, resonate with spindle apparatus. That doesn't necessarily mean they're carcinogenic. A couple of evidence, certainly colchicine and albendazole, are well-known inhibitors of mitotic apparatus that aren't associated with rodent cancer or human cancers, to our knowledge. I recently did a fairly major review of this with the group, with the International Working Group on Genotoxicity Testing, and it appears that some types of aneuploidy-inducing agents, if that's the sole change they make, that doesn't appear to be associated with cancer. They're frequently associated with other types of effects. So there's multiple type of modes of action, and then the aneuploidy does play a role and can play a role in carcinogenesis, but it's usually combined with something else. I thought I'd mention that.
Thank you. Further comments?
Not seeing any hands.
All right, seeing no hands, let's see whether there are comments from the public. I'm not aware that anyone has asked to speak, but Clara, can you verify that?
Yes, I can verify that we do not have any hands raised at this time. Again, just a reminder, if you do want to make a public comment, go ahead and click on the hand raise feature, please and thank you.
Okay, we'll wait a moment to see if anyone raises their hand.
And no one has.
No one has. So let's then take another moment and see whether there's any final discussion from the committee before we proceed to a vote. Okay, not hearing anything. Let's go down the roll again. Dr. Bush.
I appreciate Dr. Eastman's comments. I'm still going to stick with high, given the broad use of this chemical and its very similar structural similarities to oryzalin.
Okay, Dr. Crespi.
Medium.
Dr. Eastman.
I go with medium.
Dr. Lamero.
It's tricky. I think I'll go with how about medium?
Medium, okay. Seems to be the middle ground. Dr. Landolf.
Medium.
All right, and I put it in medium. Dr. Mack.
Like you, I started out with low, but I think I've come up to medium. So medium it is.
Medium. Dr. McDonald.
Medium also.
Okay, Dr. Reynolds.
I'm with Tom. I've moved up to medium.
All right, Dr. Stern.
Medium.
And Dr. Jung.
Medium.
Medium. Okay, I think we've settled on medium. So that concludes discussion of the 7 substances that we had on the agenda for today. The next agenda item on the preliminary agenda that you may have seen was a consent item, but that item has been removed as there isn't anything for us to approve at this time. So with that, we can move on to the last item, next to last item, which is updates, a set of updates from the staff. So I'll ask Julian Lechte and Carol Monahan Cummings if she's still here to give those.
Thanks. Mario's going to be stepping in for Carol, I think, but I'll start with this update on chemicals we've administratively added since the committee's last meeting. You can see on the first slide, bevacizumab was added for developmental toxicity and female reproductive toxicity, p-chlora-alpha-alpha-alpha trifluorotoluene, 2-amino-4-chlorophenol, 2-chloronitrobenzene, 1,4-dichloro-2-nitrobenzene, 2,4-dichloro-1-nitrobenzene, N,N-dimethyl acetamide, and para-nitroanisole were added for cancer. Next slide, please. Chemicals currently under consideration for administrative listing are molybdenum trioxide and indium tin oxide for cancer under the labor code mechanism. Next slide. And as you can see here, since the committee's last meeting, we've adopted 4 safe harbor levels into regulation, a no significant risk level of 0.7 micrograms per day for bromochloroacetic acid, a no significant risk level of 0.95 micrograms per day for bromodichloroacetic acid, and a maximum allowable dose level of 28,000 micrograms per day for the oral route of exposure and 20,000 micrograms per day for inhalation for N-hexane, and a maximum allowable dose level of 0.58 micrograms per day for the oral and inhalation routes of exposure, and 7.2 micrograms per day for the dermal route of exposure for chlorpyrifos. And on the next slide, you can see that we've also proposed safe harbor levels for 4 chemicals. We're still in the regulatory process for safe harbor levels for p-chlora-alpha-alpha-alpha trifluorotoluene, trichloroacetic acid, dichloroacetic acid, and dibromoacetic acid. And with that, I'll turn things over to Mario.
Okay, thank you. Okay, good afternoon. And these are some of the recent completed and open rulemakings. The coffee regulation became operative last October. And under that regulation, exposures to listed chemicals in coffee from the roasting of coffee beans or brewing of coffee are not considered to pose a significant risk of cancer. We also modified the Article 6 clear and reasonable warnings. In particular, the responsibility to provide warnings for consumer products. And in that regulation, we clarified the responsibility of the intermediate parties in the supply chain to provide Prop 65 warnings. That became effective this past April. We also have an open rulemaking for another amendment to Article 6. And the main change is to conform the alcoholic beverage tailored warnings to a consent judgment related to the delivery of alcoholic beverages. And we're close to finalizing that rulemaking. And we are currently reviewing public comments for a proposed rulemaking related to chemicals created during cooking or heat processing. And in that regulation, if a chemical is formed from cooking or heat processing and the chemical is reduced to the lowest level currently feasible, there's no exposure. And we also have included a list of concentration levels for acrylamide, and those are primarily based on settlement levels. Next slide, please. Okay, next I'll talk about the Prop 65 related litigation. Wheat growers v. Zeiss is a case related to glyphosate. It's a federal case. The district court found that warnings for glyphosate were in violation of the First Amendment limitations on compelled commercial speech. OEHHA is no longer a party to that suit, and the Attorney General has appealed that to the Ninth Circuit. The next case is American Chemistry Council v. OEHHA, and that is the BPA case. And this was a challenge to the listing to BPA, listing of BPA as a developmental toxicant via the authoritative bodies listing. The listing was upheld by the trial court and the Court of Appeal. And then the next one is the ACC v. OEHHA, that is DINP case. And the main issue was whether the committee followed written guidance when it made its decision during the meeting. The trial court and the Court of Appeal both upheld the listing, and the California Supreme Court has declined review. And the next is the Council for Education and Research on Toxics v. OEHHA. And that's related to warnings for coffee and associated Public Records Act requests. CERT, the Council for Education and Research on Toxics, dismissed all but the PRA claims, and the court entered judgment against CERT on the PRA request. Another challenge is from CERT is the CERT v. Starbucks, and that was related to the coffee regulation as part of an enforcement action, and the trial court upheld the regulation and entered judgment for the coffee companies. And finally, we have Physicians Committee for Responsible Medicine v. Newsom, and this was a challenge based on OEHHA's decision to not list processed meats. And a hearing is scheduled for February 21st of 2021. And that concludes the regulatory and litigation updates.
Okay, thanks, Mario and Julian. Thanks. Then we move on to the final agenda item, and that is a summary of committee actions. And for that, I'll turn it back to Director Zeiss.
Okay, thank you. We do have a slide that summarizes the committee decisions. Thank you. So the committee considered 7 chemicals for recommended priorities for consideration for future review by the committee for possible listing. And those selected we would develop hazard identification materials on them. So 2 of the chemicals the committee ranked as high, bisphenol A and perfluorooctane sulfonate and its salts and transformation and degradation precursors. 4 chemicals were ranked medium, chlorpyrifos, DECA, BDE, methyl bromide, and trifluralin, and 1 chemical, coal dust, was given the rank of no priority. So that summarizes the committee's decisions today, or recommendations today. And I guess I would just like to add at this point my thank yous on behalf of OEHHA to the committee for all the hard work that you did today at the meeting, as well as all the preparation prior to the meeting. It was a lot of work, and really appreciate all the thoughtful review that you provided to us in the consultation. So thank you so much. Also like to thank the Reproductive and Cancer Hazard Assessment Branch and our new Deputy Director for Science for all the work in preparing for the meeting, pulling the materials together. That too was a lot of work. So thank you for all that. And then to the implementation team, Julian, Esther, Tyler, Monet, for all their work in pulling this meeting together, as well as our IT staff. It's beginning to sound a little like the Academy Awards, but it does take a lot of individual effort to pull off a meeting like this. And I'd also like to thank Clara Robinson for her excellent facilitation of the virtual meeting, and also to our legal staff, Carol and Mario. And with that, I'll turn it in and also just wish you all good health and a good Thanksgiving next week, and be well and safe journey if you are going to be traveling. And I'll turn it back over to Dana.
Thanks, Lauren. I'm Dana. Well, I'd just like to echo those thanks to colleagues on the committee for your efforts pulling together this review and thoughtful comments on the chemicals we considered today, and for working through these circumstances, which are not optimal, certainly. And thanks to the staff for all of the work they did in the background to make this meeting possible, and to the members of the public for their interventions. And so with that, I think we can adjourn the meeting, and I will give my apologies for a rather awkward participation by phone here, and go look for some candles because it's already getting dark. So we are officially adjourned.
I should have added a special thanks to Dana for filling in. So thank you. Yes.
Nice to see you
You're
all.
most welcome.
Okay.
Everyone.
Special thanks to Dana, despite all obstacles. Thank you so much.
Yes, thank you to everyone. Thank you to OEHHA staff and Dana for doing a great job sharing.
Thank you.
Okay, thanks everyone.
Thank you.
Happy Thanksgiving. Bye now.
Next meeting.
Bye.
Quit.
Bye.
Ciao.
Ciao.
See you, Dave.
See you, Jim.